In just a second, everyone. We're just about to start.
Mamá, पूरा पानी गिराती है, साफ खराब करती है।
Hey, Nana, shall we start? Can't hear you. I think you're muted.
Yep. Let's go for it because everyone's on now. And Noor is here. Yep.
Excellent. Thank you so much, everybody. Thanks a lot for joining us today, and thanks also to all the participants. This is the 42nd edition of the IFCRA Masterclasses, this time co-hosted with the MESA. And my colleague Nana is with me. And Nana is co-hosting the masterclass with us for several occasions now, and it's been going very well. So for the second time, we are doing a review of the World Malaria Report. We did one in 2022. At the end of 2022, on December 15th, 2022, we did a review of the World Malaria Report 2021. And that was fairly well received. This was right after COVID. So there was quite a lot to capture. We have agreed with our WHO colleagues, Professor Noor Abdulsalam is here, that we are doing a new review this time for the World Malaria Report 2022. This time, however, we will also spend a significant amount of time speaking about the R&D portfolio that has been highlighted as a major component of the report. One special characteristic of these reviews is that, unlike our other masterclasses, they begin with an overview from the WHO. So Professor Noor will provide an overview of the work that is in the report. And then after that, we will begin the conversation. So I think I should invite Noor to do that. And then after that, we will begin as well. So, karibu sana, Noor.
Fergus, I'm trying to figure out how to go about sharing my slides.
It should be possible for you to share, no?
Let me give it. Let me try it.
Yeah. You able to?
Yeah.
Excellent. Excellent. While Noor is preparing, I just want to point out that we have experts from different organizations today. We have experts from MMV, experts from FIND, experts from WHO itself. We have our colleagues from the Bill and Melinda Gates Medical Research Institute in Boston. And then we have our colleagues from IVCC as well. And hopefully we will have a number of you participating during the conversations too. Karibu Noor.
Sante, can you see my slides and can you hear me clearly?
We can hear you very clearly and we can see your slides as well.
Thank you. So I will give you a brief overview of last year's World Malaria Report, which was around 4 thematic areas: response, risk, resilience, and research. And I know today's focus will be on the 4th thematic area of the World Malaria Report. But in my next few slides, I would like to set the scene around the other 3 responses to particularly link it with how research is a key part of getting us back on track towards the targets, the global targets that we've set. So we had a number of key messages, and in each thematic area, we had a key message. And the first key message to come out of last year's World Malaria Report was that despite the clear and obvious effect of the pandemic in terms of disruptions of malaria services and on social and economic systems, there was a huge global and country response to mitigate those consequences. And the net effect of that is there was an increase in the first year of the pandemic, particularly when you look at deaths from 568,000 to 625,000. And in the next year of the pandemic, because of largely the response that took place, there were no further setbacks. That's not to say that we're not worse off than we were compared to where we were at the beginning of the pandemic, but also to highlight that for a number of years before the pandemic, we also had a flat trend in terms of the burden of malaria. And that's the reason why the WHO had called out that the progress against malaria was at crossroads, which led to the HPHI response and activities related to that response. And the HPHI is a high burden to high impact approach. This is what happened in terms of cases. We were at around 232 million cases in 2019 globally. That increased to 245 million cases, then to 247 million cases. Overall, about 63,000 deaths and 13 million cases were attributed to disruptions during the COVID-19 pandemic. One of the reasons why we think we've seen no further setbacks in 2021 compared to 2020, despite the overall negative impact of the pandemic, was the massive distribution of bed nets. 74% of bed nets targeted for distribution through mass campaigns in 2020 were accomplished, similar levels in 2021. And in fact, 2020, when you look at all bed net distribution globally through all channels, was a record year in terms of distributions of bed nets. Seasonal malaria chemoprevention increased actually throughout the pandemic, largely due to expansion of seasonal malaria chemoprevention in Nigeria. Over 90% of the increases are due to increases in Nigeria. And also a couple of countries have introduced SMC as evaluations. Those are Uganda and Mozambique. The vaccine, as you recall, was recommended by WHO, and there were 3 countries that were part of the evaluation. And those countries have continued to maintain the distribution of the vaccines in the evaluation areas. And now it's been expanded to a number of countries through the call for applications by Gavi. ACTs as well, a record year. In fact, when you look at the number of ACTs distributed by NMCPs, not a record year, but similar levels to pre-pandemic period. And 2020 was actually the highest year for NMCP distributions of ACTs. And RDTs as well. When it comes to cases and deaths in the 11 highest burden countries that account for 70% of the global burden, despite increases during the first year of the pandemic in deaths, there was a slight reduction, which is essentially within the margins of error. And a slight increase in cases, again, about decisions like IPTP, there was a drop, but again, that is very similar to what we saw in the first year of the pandemic, not changing much in 2021. In the GMS, as you recall, this is an area that has a special focus of mitigating the spread of antimalarial resistance. Significant progress continues despite setbacks in a couple of countries. Overall, there was a 17% increase in malaria, largely due to Vivax malaria, in particular in Myanmar. But when you look at falciparum malaria, which is implicated in drug resistance, artemisinin combination therapy resistance emergence, we have a decline of about 12% between 2020 and 2021, to the point where I think the GMS is on target to achieve PF elimination within the next few years. In the overall, in the countries with low malaria, those with less than 10,000, again, progress continues. A few setbacks here and there, but more than half of countries do have less than 10,000 malaria cases. Despite the pandemic, about an estimated 2 billion cases and 12 million deaths have been averted. The second key message was on the risks. A number of risks have been identified, particularly in the African region, which carries the heaviest burden. In addition to the disruptions due to the pandemic, there were many other humanitarian crises, chronic health system challenges, issues related to funding, as well as biological threats. And as you can see from this graph of incidence of malaria, there hasn't been much of a change in the last few years, and things have got slightly worse off in the first year of the pandemic. And the second year of the pandemic is similar in terms of levels of incidence to the first year of the pandemic. What does this mean in terms of being on track for global targets? We are way off track. As you can see on the blue line, the green line is where we are expected to be. In fact, 48% off track for both mortality and morbidity. On funding, despite an increase in absolute terms, in terms of dollars invested, we're still less than half of the funding need estimated in the GTS. The Global Fund replenishment, as many of you know, did not go as well as planned. One of the risks we focused on particularly is around the tools in this World Malaria Report, paid a particular attention to bed nets, and we looked at the issues related to bed nets, both from across 3 areas: the aspects related to retention and behavior, aspects related to physical durability, which then, of course, inform retention, and then the potential consequences of insecticide resistance. And you can see when it comes to net retention, whatever the cost, the median year is about 1.9 years. And very, very few countries have net retention of the expected 3 years. Is a huge gap in a number of scenarios related to effectiveness of ITN. And there are several scenarios here which I will not go through, from the most idealistic here at the top, all the way to what we think is the realistic level of ITN effectiveness currently, when you start accounting for issues related to access, coverage, retention, physical durability, insecticide resistance, and all of that, which clearly demonstrates that ITN effectiveness is a lot lower than we generally expect, but also that it wanes fairly quickly, and so that by the end of the third year, you have very little to talk about. We highlight something related to IRS. I'm not going to go into the details. We talk about HRP2 deletions. We also talk about invasive species, and as well as the WHO initiative to stop the spread of Anopheles stevensii. We do focus quite a bit on ACT resistance, partial resistance to artemisinin in particular. We have already mentioned the issues in the GMS, but we also look at the new strategy to respond to antimalarial drug resistance in the African region, given the evidence that's emerging in the continent of artemisinin partial resistance. The other risks I will not go into in detail: humanitarian crisis, issues related to data, the continued effect of the pandemic. There are a number of things related to resilience, and I will quickly go through this. And one of the resilience, of course, is the response demonstrated globally and by the countries in order to mitigate the consequences of the pandemic. But the role of country leadership has been essential in this, the role of global coordination, and as well as global funding, in particular calling out the COVID-19 response mechanism, as well as flexibilities in the PMI core funding. As far as WHO is concerned, we've responded with a number of strategies and guidance, including a recent one related to the response to malaria in urban areas, which has very close links with the Anopheles stevensii initiative, as well as many other factors related to response to malaria in urban areas. I mentioned the consolidated WHO guidance, which is continuously being updated. And finally, I will move into research, which is the theme of today's masterclass. In the report, we highlight the role that research has played in ensuring progress against malaria. By the time the Abuja Declaration was launched, we did not have many tools in our arsenal. A lot of the drugs that we had were failing. And subsequently, there has been quite a lot of progress, both in insecticide-based interventions, as well as antimalarials and diagnostics. And so there's been a major part of our global response. But we also know they are faced by a number of challenges. And WHO has been trying to catalyze the landscape by trying to develop PPCs to address the gaps in tools and define the preferred product profiles. And we've also worked with our product development partners, many who are represented here, FIND, Unitaid, MMV, IVCC, in order to catalyze this space. And the report does focus on a number of the tools that are in the pipeline, which I think will be the discussion today. And I'm not going to go into the details of that. A number of key opportunities, of course, emerging in the vector control space, whether we're talking about new ITNs, new generation ITNs, or other types of vector control interventions. Vaccines, we already have the RTSS. The R21 has been in discussion and is right now very hot in the topic at the global level. We're talking about monoclonal antibodies and potentially the emergence of mRNA as an avenue for development of malaria vaccines. I will stop there for now, Fredros, and just to say that all the information and the slides that I have presented are available online. And please, there's an app that works for both Android and iOS, which you can download on your phone, and you can get all the latest statistics, WHO policies and recommendations, as well as the WHO terminology book. Thank you.
Thank you very, very much, Professor Noor. I think, first of all, it's important for all of us to recognize how much this takes, and to congratulate you and your team and everybody at WHO for producing such a fantastic report over several years. I think this is, in my opinion, perhaps the best consolidation of the information that we need to have regarding the disease every year, and the reports have continued to improve in the years past. So thank you so much for that. As you say, we're going to have a very extensive conversation about the different aspects of this report but more so on the R&D portfolio, R&D aspects to this. We would like to, I just would like to let you know that we have a limit for the past 2 meetings. We have a limit of 300. So in case you have colleagues who are trying to join, kindly share with them the YouTube link so they can join. Unfortunately, we are unable to host more than 300 participants in the masterclass today. Otherwise, thank you so much. So in case anybody has any specific questions for Professor Noor, please post those on the chat box as well. And we invite all our experts and all other participants as well to participate in the responses and the conversations going forward. So we'll share my slides and then we can begin the conversation. Thank you again, Noor. Nana, can you confirm?
Yep, perfect.
Excellent. So, I mean, you guys do this for a long time. We try to keep track. We try to review this, and they just keep getting better. And of course, today we will be focusing on that. We are lucky to have with us a number of world-renowned experts in this masterclass. We have with us Dr. Abdullah Noor and Mary Hamel. We have also been joined by Kim Lindblad, formerly at WHO, now at PATH. And we have our colleagues from MMV, George and Wiwek. And then we have Tom McLean from IVCC. And we have 2 colleagues from FIND, Rosalind and Kevin. And we have Scott Miller from Bill and Melinda Gates Medical Research Institute. We were expecting to have Professor Abdullah Diabate, who works with target malaria on GeneRevs, and unfortunately is unable to make it due to a family commitment. And then very, very lucky to also have Professor Pedro Alonso, formerly at WHO, now at the University of Barcelona. And all of us very excited to have you as well participating. Noor, before we begin, let me just jump to a note here from your director. I think you mentioned this a little bit, but I would like you to go back to it and explain what Dr. Tedros meant when he wrote this and what you mean by response, risk, resilience, and research insofar as this report is concerned. Back to you, Noor.
Thanks. I think the reason why we communicated the content of the report around response, risk, resilience, and research is for the obvious reason. What we try and track in the World Malaria Report is primarily the global trends in malaria, as well as the in malaria burden, as well as the trends in the response. These are interventions and many other things that are related to the response. And very often we also focus on the risks, and quite often we only focus on the biological threats. We say something about funding as well. And this time we thought we will try and be a little bit more holistic in terms of the way we discuss all the risks that we're faced with in the malaria response, and dig deeper into some of the major tools that we use. And we chose ITNs, for example, because if you were in the malaria space globally, in 2015, when the paper by Samianda and others from the Malaria Atlas Project came out, there was this analysis that said 68% of all the gains we've seen in bed nets were attributed to ITS. And in the global space, it accounts for 50 to 60% of the investment. And so if that was the tool that brought those gains, will it not be worth looking at what is happening with that tool and how that may explain what we are seeing in terms of the progress stalling before the pandemic, but subsequently the new generation of bed nets, but as well as being ITNs being the bulk of how we've responded during the pandemic. One of the things many people don't understand, because we haven't reported it and we should, in terms of a specific statistic, is that even though we say nearly 70% of all the gains we've seen up to 2015 were due to bed nets, nearly 60% of all bed nets distributed globally were distributed since 2016, at a time when we're seeing global progress stalling and insecticide resistance escalating and retention of bed nets reducing, and issues related to the physical durability of the net and, in some instances, the bioavailability of the insecticide. So we took a shot at it, but then we weren't taking a shot at it to try and be negative about bed nets, but to try and then move on from that, so that people are clear about the expectations from this tool and the challenges it's facing, its potential implication for the global burden of malaria, and then anchor this on the way out of this is clearly research in better tools. And one of the things we haven't done justice in the report is research in and innovation in programmatic implementation, and research and innovation in surveillance. We've kind of focused on the tools, but those are also two critical aspects of R&D, which hopefully will come up during this discussion. So that's the reasoning behind this and the quote from the DG.
Excellent. And I mean, at a later point, it would be nice to hear from you guys also why you guys chose to highlight the item on resilience, which is also fairly unique in this. And so just hold your thoughts on that. It would be nice. The 2 points you raised about innovation around surveillance and also innovation around implementation, I think these are really, really important. We will have some discussions around this as well, including discussions around community health workers and how they support processes around here. Let us go back now earlier here. I mean, the report has a lot of good news and a little bit of bad news, if you like, or not so good news. So, you know, we start with the big numbers: 2 billion cases averted, 11 or nearly 12 million deaths averted since the year 2000. But then there is also the story of 620,000 deaths for a disease against which there is actually a fairly good medicine. So in that sense, and you were saying for both deaths and cases, we are approximately 50% off track. Professor Alonso is with us here. We would like to send this question to him and also to the rest of the panelists. Anyone can address this after Pedro, actually. But the question here is, our strategy hasn't changed much since 2015, since the GTS was drafted. And for 3 years now, we say we are off track. And last year, we said we are off track. So do we really expect to go green when our strategies are still blue? Pedro, is this a question that you would like to take, please?
Hello.
Yes,
Pedro, can you hear me?
We can hear you very well.
Excellent. I missed the very last bit of your question, other than saying, can you take this on, Pedro?
Yes, we'll. I mean, Pedro, for 3 years we said we are off track. Actually, more than 3 years, we said we are off track, given the GTS targets. We want to be on the blue line, but we want to be on the green line, but our strategies are designed for the blue line, essentially. And as far as I remember, many of us, we haven't made any significant changes on the overall strategy for malaria control. I might be wrong here, you guys can correct us. Do we actually expect that we will go to this green line, or is this a song that we will sing next year as well?
Oh, now that I'm a free man, I can. That's what they told me the day after I left the WHO. They sent me messages, different friends saying, "Congratulations, you're a free man again." So
yeah,
no, I think we're simply not going to make the green line. And I think that that's for a number of reasons. One, and we've been calling this out since 2017. And at that time, WHO was very heavily criticized because we called the World Malaria Report at a crossroads. And people sort of said, you're being so exaggerated, we need a more positive view on things and so on. But at that time, I remember discussing this internally and with Noor, the writing was on the wall. We had really been slowing down, and we needed to adapt our narrative to what the data was actually saying. And the narrative could not just go on being, we're doing so great, we're doing so fantastic, and so on, because we were actually not. Since then, as this figure shows, COVID mediated also, but even in the absence of COVID, the delta between the blue and the green line just continued to increase. So we have stopped making progress for quite a while. And it is going to be incredibly difficult, if not impossible, to get back onto the green line. Now, if I had to summarize, I think there are two elements. The tools we have and the health systems in place take us as far as we've gone. And I commend Noor and his team for having brought up this important question on the relative contribution of insecticide-treated bed nets, which is not about damning bed nets or saying they're not good. But at times there's been this unreasonable assumption that if you slept under an insecticide-treated bed net, you didn't get malaria. And I would always remind ourselves that even at the time when there was no insecticide resistance, even at the time when I dipped the bed nets myself with my friend Lindsay, and we ensured that children slept under bed nets, and this is going back nearly 30 years ago, the efficacy was never higher than 45–50%. And therefore there has been a little bit that mismatch between what people's understanding or imagination was about what the real efficacy of the bed nets is versus what it was, let alone this effectiveness decay that Noor so elegantly shows, and which I think helps us put this tool in its right dimension, rather than just the entire problem being about insecticide resistance, which has been the narrative over the last few years. Oh, it's insecticide resistance. Well, insecticide resistance probably contributes a bit, but there are other factors that do so. Anyway, just to cut a long story short, I think we need new tools. And again, that's why I commend Noor for highlighting this in this report. Without new transformative tools, it is going to be very hard to get back on track. And then the second thing is, let us acknowledge that there is a massive resistance in the malaria community to adopt change and flexibility. When we've been calling out for the need to move on from a one-size-fits-all approach to a much more targeted, data-driven implementation of the best combination of tools for a given setting, there is resistance. There is resistance within GMP. There is resistance within WHO. There's massive resistance within the Global Fund. There's massive resistance within RBM. By many of the key actors, there is massive resistance to change. And unless we unlock that, progress is going to be very hard. When it was obvious that in some places, 4 rounds of SMC would leave a significant proportion of children during a high-risk time unprotected, and all it required is to extend one extra cycle, there was huge resistance from the TRP of the Global Fund, from the Global Fund leadership, from many of the actors. That is nonsense. That is real nonsense, unscientific nonsense. We have to be smarter, because when you look at this figure, we know where we're going to be at the end of this century, of this decade. And we're going to be with a huge malaria problem and an unacceptably high number of deaths. And the community will just feel very satisfied and pat itself on the back saying, oh, we're really doing great and we're making progress. No, we're not. We're not making progress at all. We have a real malaria crisis. And that malaria crisis will only be sorted out if we accelerate our R&D effort, develop new transformative tools, and we unlock the hold that the conservative thinking has on the malaria programs in Africa that prevent them from doing the smart thing to do.
Thank you very much. Thank you very much, Pedro. I 100% agree with you. And to stay ahead of malaria, really, we require innovation. We need new strategies and, importantly, new ways of thinking about the malaria problem. I think that's very, very, very nicely said. And of course, malaria has been with us, humankind, for many, many years, a millennia and counting. And drugs, insecticides, we're going to we obviously expect resistance, and we have to think much, much differently to the way we're doing things now. Interestingly, Fredros had a conversation with ChatGPT, and Fredros, would you like to show that and comment and ask?
Yes. This is an interesting one. But first of all, it's really just it's kind of interesting that Pedro is choosing the message that we have a malaria crisis. Yeah. Often we want to convey this message that we are making progress, and clearly the difference between the blue and the green line is quite big. So that's an interesting conversation in itself. But I want to send this back to our other colleagues as well, Scott, Kim, Rosalind, Kevin, Tom, Vivek, and George. If you guys are online, anybody can take this. We had a conversation with the AI, OpenAI system, ChatGPT, and we asked the question that we would ask any malaria expert. We said, well, if you had all the money in the world and you had all the authority to make all the decisions, you're like the ultra powerful individual, and you have all the money, what would you do to eliminate malaria? And this is what ChatGPT said, fairly straightforward, 6 points. The question we have for you is to try and challenge this or agree with it in whichever way, and just the point here is just to try and figure out whether the things that we should do are so obvious that AI can tell us, or if there's anything more that needs to be done here. So we can begin with you, perhaps, Scott, if you don't mind.
Sure. First of all, it's wonderful to be able to join you today. And I guess I just would amplify on some of the comments from Pedro. I think when you look at this divergence of where we are versus where we want to be, again, I think if you take the long-term view, what you're seeing is why there's a call to try to eliminate malaria. We will always be in this battle of never being able to get rid of this disease unless we can get to zero. Because if you can get to zero, you can prevent what we see here. But we're not there. And I think the key message, I guess I would say, I'm no longer in my old job as a funder in the elimination space. But we don't have the tools to eliminate. I think that is very clear, and we can talk a little bit further about how hopefully the R&D to try to make new tools. Those tools certainly can be applied and need to be applied for burden reduction, because I think my vision would be that, and I think it's shared by many on this call and certainly at the Gates Foundation, is on that road, which will be a journey to get to zero, we want to save as many lives as we can along the way. So we have to be able to find solutions to reduce the burden today, and at the same time to develop tools that will get us to zero in the future. And I think that also gets lost in the narrative a bit, as we talk about, introducing the malaria vaccines, which will be a huge advance for burden reduction, but the current vaccines will do nothing to help for elimination. They are not elimination vaccines. They don't prevent infection. Therefore, they will not break the cycle of transmission. And I think that message is getting also lost in just the challenges of bringing new products forward. So I think I'm certainly glad that we can get to talking about some of the specifics, but I think when we talk about eliminations focused R&D, like the projects that Dr. Diabate is working on, and even some of the hopefully new tools that will be coming from what we learn about, for example, with these first generation vaccines, how we can make a better vaccine. That is all part of that R&D journey. But maybe I'll stop there now and not get too much into the specifics.
Right. Thank you so much, Scott. And thanks, by the way, for joining us. It's good that you're on the right time zone to be able to join this morning. Thank you so much. And many of us still remember you from your days as a funding partner, and we are grateful that you are taking the road with us. Anyone else who wants to weigh in on what we could do to go to zero? Tom, Kim, you guys there? Vivek?
Yeah, I just wanted to make an observation. Sorry. Hey, I'm Ros.
Yes, go ahead, Ros.
So we are focused on diagnostics. And I think if you could just go back to the slide with the 2 lines, I think one of the things that is really striking when you read the World Malaria Report is the diversity of challenges that's being faced and the heterogeneity across areas. And these lines present the global story, but underlying that is such a range of different challenges and different success stories that some of that can get lost. And I think remembering the nuance around, the challenges in different places being wildly different is really key in these discussions. And there are many, big success stories in the World Malaria Report this year, as well as some areas where clearly there are big challenges. And then the message, from that for us as product development partnerships and sort of trying to support the R&D pipeline and getting new tools out is really that we need a really diversified toolkit as well, so that countries can select the right tools to meet their local challenges in the most cost-effective and productive way. So yeah, that's always my key thing, is the diversity that is kind of hidden behind these global numbers.
Thank you so much, Rosalind, for that. And I mean, I think you raise an important point here. Also, I believe you mean the differences between geographies, that there are places that are actually making a lot more progress than others. Is that right?
Yeah, exactly.
Cool. Back to you, Nana.
Yeah. Thanks, Frederick. Okay, so Noor in his presentation mentioned that they're promising R&Ds, new promising research and development in the pipeline. And we know that there are lots ongoing, and we'd like to find out from all of you here, and very briefly though, from FIND, MMV, WHO, IVCC, and also Gates, what's new and what's promising in your pipeline. And I think, Tom, you had a slide you wanted to show with us here. Perhaps this might be an opportunity when it gets to your turn.
It probably would be best if I use that at the end, because it brings together a number of other pipelines. So, but perhaps if we could hear from some of the other partners, and then I'll wrap up.
Perfect.
Correct. We noticed that Mary joined already as well, so that's fine. We still have one expert locked out. Unfortunately, we're trying to get him in, George, MMV, but hopefully he will be able to join. Yeah.
I'm not sure if this is the right moment. Did you want me to maybe address some
Yes,
of
please.
the new medicines and drugs in the pipeline? Because there we have a variety of interventions on this slide. Looking for some guidance.
Yes, and we will have a long discussion also in your own portfolio, but right now just mention very briefly what are the main things that are in your portfolio that we should be looking out for.
Right. Well, so from MMV's perspective, we're still very much into drug development. So new classes of antimalarials, we believe that there is still room for those addressing different stages of the parasite life cycle or transmission blocking and switching maybe from the straightforward treatment of blood stage disease into more sort of complex paradigms. And then a big emphasis on chemoprevention. As Scott said, the vaccines are a great step forward, but we believe there's still probably going to be a transition space in which vaccines have to coexist with drugs and sort of support each other. So I think that's an area that we'd like to understand a bit better over the coming years. I'll stop here and hopefully George will come into this forum sometime soon. And by the way, I didn't introduce myself. My name is Viveka, and I'm the head of product development at MMV. Thank you.
Thanks, Viveka. Ivy, I'm from IVCC.
No, from MMV.
No, I mean, we can have someone from IVCC as well to give us their.
Okay. So
Yeah. Tom, did you want to share a slide? You want me to stop?
Yes, I will, if I may. So before I share this slide, I just want to echo many of the things that Pedro was saying here. First of all, to say that yes, we completely agree that it was unreasonable to expect a bed net ever to get beyond about 50% efficacy, but 50% efficacy is really one of the best things we have, and that continuing to maintain the efficacy of bed nets is going to be an absolutely crucial part of our work over the next couple of years. And you'll have seen the results from the chlorphenapir net that has been brought forward by BASF, a long and resilient effort on their part to bring that product through the process and get it into the marketplace, showing an odds ratio of 0.45 against a conventional pyrethroid net in places with resistance. So I would slightly disagree with your comment, Pedro, that resistance makes a small difference. We think that resistance makes a big difference, but that there are products that are going to combat resistance that have come through the pipeline, and there are more in the pipeline. There's a whole lot more coming. And that's true both in IRS, where for almost 10 years now, we've been steadily bringing through a number of products, starting with Actelic, the pyrimidine methyl product, and then moving through into the neonics, the clothianidin products. And there are a couple of things that are in the PQ process now that will come through to support the idea of rotation, and in particular subnational rotation in all of these things. So we see that those things can contribute substantially to bringing us back towards the green line. I don't expect to get back right onto it, but that's not going to take us to elimination on its own, that we really do need something completely transformational. And we agree that those things are going to come from many different kinds of intervention, but also in vector control. And in particular, the thing that we see that looks really extremely promising in vector control is the targeted sugar bait, where this is a product that works. It looks like a little like a sheet of paper, A4 sheet of paper, in which there is contained a bait that attracts mosquitoes and a film over the top that prevents other things than mosquitoes from being killed by it. And this is currently in epidemiological trials in Mali and Zambia. And we hope to see the results of that over the next 18 months or so. We just don't have the data yet. We are in that phase where everybody has to stay away from the data and hope it will come out positive. But the modeling looks extremely good. We have 3 independent modeling groups, all of whom have shown that the use of something like this in areas where there are other interventions as well, alongside bed nets and SMC, can drive to elimination. So we are optimistic about this. But in order for that to become true, the comment that you make about we need to move into a world in which the malaria community and the process for approving products and listing them, and the process for developing policy and recommendation, and then the process for procuring those products is much more flexible and much more responsive to the real science than it is today. And I would echo completely your comment about the need for those processes to reflect the changes that are coming. So if I may, I would like to end with one slide in which we have drawn together a lot of information, not only from IBCC's pipeline, but I will beg the forgiveness of many of my partners for showing some other pipelines as well, because this is a slide that made a big impression on us when we saw it, and I think it's worth sharing.
Go ahead.
So I hope you are seeing now a slide that has a timeline along the top and then a number of colored boxes underneath. So along the top is the IBCC current pipeline. In this year, we're expecting to see a couple of IRS products that you will see in the top left-hand corner. Then a product is not an IBCC product, but a vector control product of great interest from SC Johnson about spatial repellents. And then under these, a whole series of bed nets with new active ingredients on them. You'll know, I'm sure, about the chlorphenapir net that is already in the marketplace. There will be a generic version of that is currently in the PQ process, and we're expecting soon. Then products based on new active ingredients, tenebanal in 25 and 26, and then other active ingredients beyond that. But if we look below that, we also see around 2025, 2026, attractive sugar baits coming. The vaccines, RTSS is here now, Matrix 21, maybe somewhere around 2028, and a large collection of the pink boxes that are new drugs coming through. On top of that, we have things like ivermectin, monoclonal antibodies, and then eventually the gene drives. And the message that this sends to us is that the pipeline of things that is coming through is enormously crowded. If we imagine how difficult it was for us to bring through the chlorphenapir net and the very large number of people that needed to be brought together, our friends in the industry at BASF to make the product, people from the country programs who ran the trials to demonstrate that it really worked, the control programs who did the pilot introductions, people in PATH and in universities across Africa and the rest of the world. If we imagine that effort, not to mention $60 million from the Global Fund and UNITAID, we can't imagine that we can do that every year for the next 10 years. We have to have a much smarter, lower barrier way of introducing new products, because this pipeline is incredibly crowded. And we won't be able to devote that level of effort to introducing every one of these new things. So the plea that I bring is that we think about how are these new things going to be introduced? And what is the process whereby we are going to make decisions about them? Now, Fredros, in your comment earlier, you were saying that we were still working with a 2015 policy that left us on the blue line, not the green line. I'm going to disagree with one element of that. One thing about policy that really has substantially changed in the last couple of years has been the introduction, and I would like to express great admiration and respect for the way this has been introduced, of subnational tailoring from Noor and his colleagues at WHO. We are great admirers of this idea. And we think that this idea about really choosing the right product for the right place is going to be really critical. And especially when we see this diversity of new products arriving. How will people decide which of these, a wide range of new products, to choose? Well, I think the answer lies in the process that Noor is developing. But as he said, and I will not claim my credit and insight for this, is something that many people have said to me, starting with Noor. The real driver for this is data. And we can't make those decisions unless we have data going back. And I remember many, many years ago, Pedro saying, data is an intervention. And I think that a key thing that we need to talk about in all of this discussion about innovation in product and implementations is innovation in how you collect and manage data, because we need that in order to be able to drive the decision making here. So I'm going to stop there.
Thank you very, very much. I mean, Nana, did you want to summarize, or shall I go? Yeah, I think so. Tom, you raise an excellent point here. Number one, the portfolio is definitely crowded for good reason, crowded in a positive way. But that itself brings the challenge of how exactly do we decide how to package them. Of course, you also raised the question of subnational stratification, and Professor Noor is here. Hopefully, he will weigh in onto that, and how then that idea is adapted to deploy the different technologies that are coming up. You also raise one thing that I think you miss out is the idea of cost. So the fact that we have, a full pipeline does not necessarily mean they will be available, and we will be discussing today how much funding actually is available for deploying these things. At the moment, people are having to choose between one or the other. It's not, we are not saying, okay, now there's ATSBs, let's put them on top. Okay, now there are monoclonals, let's add them on. Countries are having to choose, and this is a conversation that it would be really nice if our other partners can weigh in on as well. We see the hands of Kevin and Pedro, and please join in. And Mary.
I think Pedro was first, so I'll go in after Pedro. Do you want to lead, Pedro?
Yeah, no, happy to comment. Thanks. Very briefly, I think Tom has raised an issue that is really, really important, and we often overuse the term strategic, but I think in this case it is strategic, which is around how do we manage our pipeline of innovations and get them actually implemented. And we have a good pipeline of innovation, both from the drugs, the insecticide treated bed net, the vector control space, monoclonals, vaccines, and so on. And then we hit the hard reality of when you bring in a new product forward, there is a sum zero budget, and therefore that generates a really unhealthy competition, which we saw in the case of RTSS with existing tools. And let us be frank about this. Somehow the vector control community felt threatened because there was a first generation vaccine being brought forward. And they were all about, oh, we need to protect our insecticide-treated bed nets. And if there is a vaccine is to be funded, it should be funded by someone else, not by Global Fund. And therefore, it should be
Pedro, do you have evidence for this statement?
Yeah, plenty. And it should be done by Gavi. And then they said, well, I mean, the director of the Global Fund would say, oh, we have to use relative cost effectiveness as our key data base on which to take decisions. Well, let's also be very clear about this. There are no good cost effectiveness data of each tool in the different epidemiological and contextual settings to be able to perform a proper relative cost effectiveness assessment. So we need to generate that data, and we need to be able to compare apples with apples and pears with pears. And right now, we don't have that information. So it is remarkable how the malaria community then goes into their own silos. And I need to protect my SMC, I need to protect my insecticide-treated bed nets, and therefore I have to downplay the vaccine, let alone when the monoclonals come along, how is that going to be dealt with? But even within the drugs, let us remember that we've had anti-malarial medicines, highly efficacious ones, in fact, some of the best performing ones, like artesunate pyronaridine, that have not really been allowed to enter the market. And therefore, the company will have to close the production of that innovation. So we may have a robust pipeline of innovation, some of which, even if it succeeds in producing a valuable product, may never be used and may be thrown out of the market. So this is a really important area that Tom has brought forward that will require the malaria community to have a really hard, honest look at it. Thanks.
Thanks, Pedro. I guess I want to open up with just a question around the question of approaching malaria zero, and whether that is actually going to be achievable in every country, and whether we should be thinking about achieving near zero or adjusting our approach towards malaria zero, depending on the location or geographical specific area. I just want to throw that out there. Someone else can answer that. I guess one of the things I wanted to approach, based on what had been said before by others, was we really should be looking at this as a multifaceted approach. And Pedro had touched on the idea that there was some silo mentality trying to approach some of these problems. And I think being able to really strengthen what we can do in terms of diagnostics, or what we can do in terms of drugs, or what we can do in terms of control, I think that multifaceted approach is what's going to be needed to really get this through. And I don't think anyone's really going to argue with that sort of perspective. I think we have a lot of in some cases, we have the tools that we need, but in other cases we don't. And I think in the diagnostic space, where Ros and I are sort of more anchored, there is more opportunity to bring much more innovation into the way diagnostics are used, such that a single platform might be answering a question on multiple diseases, so that you're able to look at what the question is in terms of malaria, but also what the question is in terms of other confounding sort of infections. And I think the situation we went through with COVID kind of gave us a good example as what we needed to do in terms of looking at what other aspects might impact on the progress and control of infection. We've seen the impact in terms of what it had in terms of funding, and in terms of being able to employ and deploy available strategies, which, having them knocked back, I think Noor gave a good summary at the beginning, showing what impact that had on the number of deaths that were increased due to the pandemic. I guess the main thing I'd like to push is, one, is the fact that we need this sort of multifaceted approach. And two, we really need to be putting more aspect on the idea of diagnostics, but also on surveillance, because obviously if we look, we can find, and if we find, we can target the strategy. I think I'll stop there, because otherwise I'd threaten to go off on a tangent. So thank you.
No, Kevin, before you stop, why don't you just, maybe you can just skip a little bit here. Why don't you tell us then a little bit more about what FIND is doing in the diagnostic space with regard to malaria, this challenge of going towards zero.
Okay.
How is FIND trying to solve that from the diagnostics perspective?
So I think one of the things that the primary driver for FIND is really looking at making sure we can get innovative tools, but getting them in an accessible way. So there's no point making some very fancy pieces of kit, which are incredibly expensive and very difficult to run. What we're trying to do is really trying to drive that innovation such that we can deploy the kind of tools that have longevity and sustainability within the public healthcare system space. To go into a little bit, I can't go into absolute specifics, but the kind of things that we're really interested in is really trying to, and I touched on this a few moments ago, is really trying to drive the kind of diagnostics that allow us to look at multiple things at once. One that allows us to really keep the costs low. It means that we can have these things in the public healthcare space, which allows us to get quite a bit of information straight away very quickly to be able to drive that sort of narrative in terms of what's going on. Because in most cases, it's not a mono infection that's taking place. Your infection is sitting within a landscape of other infections as well. And being able to understand that context, that interaction will help within those with those sort of treatments. Non-invasive sort of approaches are the sort of things that we're kind of interested in. We're really kind of looking to investigate in that space to see what we can do and what we can bring to bear. Because we think uptake of those kind of tools will be very useful, quite powerful. And it will allow this aspect that I mentioned before about the idea of being able to test multiple diseases in any one sort of space. I'm not trying to sell the idea that we're trying to push for the kind of Tyrannus style approach. We're a bit more realistic than that. But there are technologies out there that
one drop of blood.
Yeah. Indeed.
Yeah.
But there are technologies that are out there that exist in multiple different spaces that we can, if you like, redeploy or retask to answer the questions that we want. And that's kind of the space that we're in. Yeah, I think I can field a bit more questions, but I don't want to go into too much more detail than that. Yeah. Thank you.
Can I just say something very quickly? So
go ahead, Dana.
Thank you very much, Kevin. Actually hit on some point we wanted to bring up as well. Just one little question in addition to what you just said. Was there an impact due to COVID on the R&D for diagnostics, and also on the point you touched on just now in terms of trying to have like combo tests? In terms of discriminating, for example, malaria and other febrile diseases, are you thinking in lines of how to detect malaria, not just that, considering the symptoms could be similar to things like COVID, for example, and then also from the other end of the coin for the health workers to discriminate between the infections? Are you thinking in lines of all of this, and how do they connect?
I clearly wasn't quick enough to jump off. There's a whole line of good questions there. In terms of its impact on funding, yes. I mean, I didn't introduce myself. My previous life, I was a associate professor in infectious diseases, and my focus was really malaria and a number of other infections, Ebola, COVID, etc. And I would say that once the pandemic hit, the malaria research, in terms of my engagement, I mean, nor has shown this in actual data, but in terms of our engagement at the London School, we got battered. I mean, we had to pivot. We had to try and move a lot of our tools and try and use them to try and answer questions about COVID. We were lucky. We got funding from partners like the Gates and others to be able to look at the interaction between malaria and COVID. But for those who weren't able to pivot and utilize their skills and platforms in that way, there was a significant hit in terms of funding for other infections, including malaria. So yeah, that was a pretty big hit. I'll try to remember the other questions you had. In terms of the public healthcare sort of arena, that is a primary focus for us. We want to make sure that whatever we deliver is able to engage and interact with clinicians and public healthcare practitioners on the ground. It's, in fact, that is a main drive, because if we can't do that, then we can't get that uptake, we can't get that engagement. You did have another question. Do you mind repeating? There was one in the middle.
Yep, that was if you were getting like combo diagnostic test that moved
yes.
to, yeah.
So with the combination diagnostic tests, I mean, what we're really trying to do at FIND is really have a matrix sort of approach to the sort of disease spectrum that we have. And so there are a number of different diseases that my colleagues and I are looking at, and we really want to look at the interaction between them, because none of them operates in a silo, even though sometimes it's quite convenient to treat them in that way, but they never operate in that way. So what we're trying to do is really, when we think about all the approaches we're talking about, and I'm talking about targeting more than one infection in any one space, what we're really thinking about is trying to answer those questions across these sort of disease spectra. And that includes non-communicable diseases, because obviously, again, if we go back to the question about COVID, we could see straight away the exacerbating effects and the impact that underlying healthcare infections of the non-communicable variety had on the progression of the disease. So yeah, there is, those facets are kind of core to the elements when we try to devise our strategy and we're taking this sort of story forward. It's all core, because if any one of those elements doesn't really stand up, then it's going to make it very difficult for us to implement it. And as I said to Pedros earlier on, we really want to get these in a sustainable way, so that once it's deployed, it's not something that's going to fall apart in 2 years' time. It's something that's going to be an integral part of the PHC, or public healthcare system. Did I answer your questions?
You did. Thank you very much, Kevin.
Thank you very much. Thank you.
Mary and Scott, you've got your hands up, and
Kim. We have Mary, Scott, Kim. We have a number of hands up.
Mohammed.
Yeah, go ahead.
Thank you. I'm really enjoying this discussion. I wanted to react a bit to Tom's really nice crowded map, and which is, in a way, it's very exciting, obviously, to see everything in the pipeline. And then, as he said, we have to plan ahead. But it's not discouraging. I would say it's encouraging, and I think he would probably say the same. I do think it's important to map out not only what's coming, but who owns each of those interventions and who can fund those interventions. So we made the mistake a long time ago with IPTI of holding on to it in our malaria group, when actually it's a maternal child health intervention, and it goes in the ANC. And I had the experience of going and speaking to experts in maternal health who said, this is really not important to us when we have women dying in droves from hemorrhage at the time of childbirth. So we have to think about this. And maybe the field will get less crowded when we see what belongs to the ANC, what belongs to EPI, what do we keep in malaria control, and maybe the funding arms will become a little more clear with that too. Then I also wanted to just share a bit about where we are with vaccines, malaria vaccines, and as Scott pointed out, the current vaccine.
Mary, if you like, you can hold the vaccine thought just very briefly,
okay,
and then you can discuss it in more detail. But if there's something else that you want to bring up, go ahead.
I think I'll hold it for the rest of it.
You want to hold it?
Yeah, sure.
All right. And as you speaking, I just remembered that Pedro, before he left WHO, used to say that malaria people don't want to talk to other sectors. They don't want to talk to maternal and child health. And it's interesting you bring in the question of IPTP. Can I do that? Let's wrap this up and then go back to the vaccine and monoclonals. And so we're going to request Kim as well, and the other colleagues to hold, and Scott. So while Tom was speaking, we could see also this portfolio that you get in the WHO database. A lot of bed nets being tested at the moment, IRS products. And then there are several other vector control products, including genetically modified organisms, house modification, larvicides, etc., etc. One thing that Tom mentioned, which I think is worth highlighting again here, is just the incredible value of partnerships especially with the private sector, and the fantastic work that IVCC has done, bringing together these partners to create some new products. And we might not notice it, but actually in the past few years, we've had Actelic 300 CS, Sumi Shield, we have Bayer now, Envu, Fluidora Fusion, Interceptor G2 is perhaps now the most widely known, and several other products as well. And we just want to congratulate the team for that, and also for putting together such partnerships. I think I send this back to you, Nana.
Okay, thank you,
Scott.
Yep. So Scott, we've got quite a number of questions here with this technology here. So first of all, perhaps very simple, but how do monoclonal antibodies work? And then in that, maybe you can add a little bit more about the current monoclonal antibody candidates that are in the pipeline, and in terms of what parasite stage they are targeting, and then we can move to other questions on that.
Sure, and I want to take time to introduce myself briefly because I didn't really do so before. So I'm Scott Miller. I was at the head of malaria research and development at the Gates Foundation for 7 years before I stepped away this last year to actually work on developing monoclonal antibodies. And I hope you'll catch through this why I'm excited in doing this, and why this will be, I think, a nice transition to this discussion about elimination-focused tools. But I did want to just briefly comment further, just one high-level discussion back on from comments in the chat on the challenge of R&D funding. So I had, in that role when I was at the Gates Foundation, really there are 3 parallel streams that all require lots of attention and funding, and we don't do a good job of splitting these out. And I guess that would be even my one comment to Tom's slide earlier, and that's about, first of all, optimizing the tools that we have, which is all the life cycle. It's not just getting the products to market, it's actually optimizing them, understanding how to best use them in the complex ecosystems that we have, optimizing them for end users, and these issues around patient-based design and so forth. And we didn't see anywhere on that slide about life cycle management, but that is a huge, important piece. It's not just getting them to market, it's getting them to maximum impact in the market. And that is the funders that work in that space, it stays under the radar screen too much. That's one. And then secondly, I think the tools to maintain the gains, and we had to, for good reason, had to put a lot of money into making, just new drugs for case management, new diagnostics for case management, new, bed nets and so forth. And that is really focused on making sure that the products we have today will still work in the future as we're dealing with the real biological threats of resistance. And then the last one, which is very different, is actually making something entirely novel and disruptive, which I do believe we need to get to elimination. And so trying to fund across all 3 of those buckets, and one of my main jobs was try to find the right balance to continue to make products that we will need in 2035, and at the same time addressing the needs we have in 2025. As well as helping get the products better today in 2023. So I think we don't really capture that in these slides. This is what's new, but it's not just about what's new. It's about how what we have today and make it better. And I think that's just an important thing for this group to recognize. So on the monoclonals, I guess I'll say briefly, and I'll just walk through this. I'm glad to share a few slides later. For the group, a monoclonal antibody is a drug. It is I think that's a really important concept that makes it different than a vaccine. In a concept, what we are doing is giving passive immunotherapy. So we're giving antibodies, which is, of course, the outcome of many of our vaccines or natural infections, but we're giving an antibody to impact, one of the life cycle stages of the parasite. And monoclonal antibodies, of course, have been used widely in cancer. They've been used in inflammatory diseases like rheumatoid arthritis. And the whole idea of using antibodies to target infections is fairly new. And in large part, this was because to make them has been historically very expensive. And there have been big breakthroughs in coming over the last, let's say, 6 years to bring down the cost to where we can actually start thinking about these for infections. And the first infections that have been targeted with monoclonal antibodies were actually Ebola and RSV, respiratory syncytial virus. And then recently, over the last couple of years, I think people maybe became much more familiar with these, with trying to target them towards the SARS-CoV-2 virus. So as we saw the prices coming down and the potential of being able to maybe use this for malaria, we had started a series of investments now about 5 years ago. The R&D pipeline takes a long time, right? So this is a 15-year journey to go from, first ideas to actually bringing something scalable to the market. And where we are, I think the one big breakthrough has been bringing the price down, and then I'll talk about it in a minute. We still have a ways to go, I think, to really bring this to scale. But the second piece is we've learned how to engineer these antibodies to make them better than the antibodies that our bodies normally produce. So when you get a vaccine, you make I'll pick some vaccines focused on the cellular immune system, but some vaccines focus on antibody production and some do both. But we believe that most of the protection, for example, from the RTSS vaccine is antibody production. But those are our natural antibodies. And what we've done is we have modified these so that we can grow them more efficiently outside of the body. And secondly, we have modified them to extend the half-life. So an antibody that normally might last for 30 days, we can now talk about a single administration can last more than 6 months, because we've taken advantage of the body's ability to recycle these antibodies. And so that it's not like a drug where you have it and then it goes away. This will actually recycle over and over again into your bloodstream to keep the antibody concentrations higher. How long that will last, we don't really know yet. The particular approaches to do this are still all very new, and we actually now have clinical trials ongoing to really understand how long this can last, where we can keep the antibody concentrations high enough to be helpful. So those are the two big technological breakthroughs that had to happen. And I think, I'll just say one of the very exciting news, if you maybe in your country you haven't seen it yet, but you may have heard about it, is where these long half-life antibodies now are licensed in Europe for RSV and are under review in many other countries. And the Gates MRI, the nonprofit pharma company that I work for now, is working on an RSV monoclonal. Single injection will prevent, RSV for the whole respiratory transmission season, or winter in the north. Again, it's a similar concept, and there's a lot of parallel themes. We're working closely with that group to try to understand how these can work. In terms of the targets, well, of course, you can target several parasite stages. The initial work is largely focused on the sporozoite. So because we've now validated with RTSS that antibodies against sporozoites do prevent infection, or do reduce the number of infections, and can help prevent disease and severe morbidity. So it's a validated target, which is why it's easy to look at. And the current products that are either in the clinic or will be in the clinic in the next couple of months, some of those are focusing on different targets than the RTSS and R21 vaccines. So they are focusing on circumsporozoite protein, but they are different parts of the protein than are in the vaccine. And I think it remains unclear right now whether that will be a better strategy or not. My company is focusing on a monoclonal antibody that is against the major repeats in circumsporozoite, which are actually included in the vaccine, but bind at a much higher affinity than most of the antibodies. When what the vaccine is somewhat inefficient. I mean, it makes good antibodies, it makes bad antibodies. What we have done is to try to take and find the most potent antibody that was made, and then now manufacture it outside of the body and then modify it. So again, it's a complex process. I guess in the looking ahead to comment, on the use cases, a more potent prevention tool could be used for lots of different things. And so I think today, this is still an ongoing discussion about what we want to focus on first. But I think from our company's perspective, we really want to focus with the first generation monoclonal antibodies on saving lives. And we are going to focus on the most vulnerable, so young children and children with comorbidities for which malaria is not, incurs a much higher risk of mortality. So this is a small market, and I will say that I don't see, if I kind of put on my future hat, I don't see that we are trying to displace the first generation vaccines. I don't think that we will partially maybe displace some of the places that might use monthly chemo prevention, because I think this will be much easier to use if you can give one injection and protect a child for 6 or 7 months. But we see this as fitting in that ecosystem with other prevention tools. But what I think excites me about the monoclonals, and it's also a risk, it's just one of the things we don't know yet, is they are more potent. And if those of you have seen some of the papers, you're seeing no infections for multiple there So not even low-grade infections, I mean, zero. So then, what does that mean when we take it into Africa? There are concerns. If you're not building any blood stage immunity, are we just going to end up with delayed malaria, or what people might call malaria rebound? And then, how can we address for that? These are science questions we have to answer. But we have never had a tool that prevents all infections. We've always had partially effective tools, 50%. We heard with bed nets, 50% with the vaccine. Maybe the combination of the vaccine and the drugs is the closest thing we have to the monoclonals, where I think we are getting much higher levels of protection. And we need to learn from combining the vaccine and the drugs and trying these monoclonals to really understand, how we can protect a child, but then if once that wears off, how we can continue to protect that child. So it is setting, I think it's more than the impact it will have on preventing disease today, is helping us to understand what it means to actually prevent all infections for malaria in a high risk area, and how we can manage that. Because our goal in the future is to have a vaccine. The second generation vaccines are also focused on preventing all infections. So it's moving the idea from just preventing disease to preventing infections. And I would argue that is the critical prevention tool, the prevention strategy we need to do elimination, because we are not going to get to elimination if we don't eliminate low-grade infections that continue to transmit in the community. So maybe I'll stop there and I can answer some questions. One last thing I see on the last one. So monoclonal antibodies are expensive. It's funny, when I spoke at the American Society of Tropical Medicine and Hygiene, I had many people come up and said, it'll never work, you can never afford it. We are actually very optimistic that we can, but they are dosed on a weight basis. So dosing an adult requires a much lower cost product than dosing a child. So dosing an infant is like with RSV is actually quite cheap. You can do that for $2. Dosing a child up to the age of 5, we are confident we can do this and be competitive, because as I think Pedro said, there is no more money. So we can't be more expensive than the existing tools. But we think we can get there for children today. We will need further breakthroughs in manufacturing for monoclonals to get there for adults. But it will allow us to better understand, what a tool might look like if you prevent all infections, and being able to understand how to manage that if there is until you get to a near zero scenario when there aren't recurrent infections going on. So more to follow. It's still very, very early days. We hope we'll be able to have some exciting updates over the next couple of years. For those who don't know, the first monoclonal antibody is now in a phase 2 clinical trial in East Africa in children between the ages of 5 months and 5 years. So we're getting these products. We've shown that they're safe. We can deliver them now to children. And now we need to understand how it really will prevent not only disease, but all infections. So that will be data you will see coming out over the next year.
Thank you very much, Scott. That was very, very clear. Actually answered all the questions and more. Fred was right. And so
yes, except just very, very briefly, Scott, very, very briefly, there's always fear that when you have a tool as good as this, that it will immediately be absorbed by the travel industry, and that the travelers will be willing to pay all these amounts for the big doses for adults, and that will be very attractive for the industry, and that there will be not enough to protect children who actually need smaller doses at lower costs. But I imagine that a tourist is willing to pay for that big dose anyway, and that might be very attractive for the market. So that is concern number one. The other thing that you may want to address quickly is whether there's risk of drug resistance to the monoclonals as well.
I didn't talk. So monoclonals are also being looked at for other parasite life stages, both the gametocytes as well as some work on conserved targets against blood merozoites, although that's a big challenge biologically. I think briefly to address those questions, there are some groups that are looking at whether a monoclonal could be a good solution for travelers. Our company's mission is only products for low middle income countries. We are not doing that. But this is a challenge. There is the malaria, the market for good prevention tools is larger now. If the monoclonals work, and if you were to try to give it to every child under 5, it would exceed the total global monoclonal production for all diseases around the globe. So these are expensive to make. There's limited manufacturing capacity today. So we will need to have innovative approaches to thinking through, how can we manufacture these in Africa? Can we manufacture these in other low middle income countries? And we are committed to finding those solutions. But this is not something where we can plug and play into existing manufacturing capacity. It will require investment to do so. But before we make those large scale investments, we really need to show that it does work as well as some of the early data indicates. And then, obviously then the investment in manufacturing will come, I think. But that is certainly a hurdle. And no doubt there's always will be, finding a dual market for a company that they can make some money. I mean, I think it's important to know for those of you who don't do R&D every day, in malaria, the companies that make malaria products are basically agreeing to do that at virtually no profit. And that would be very unique in the monoclonal space. When you think of monoclonal antibodies, you think of spending $1,000 a dose, and we are committed to bringing this to market at less than $10 a dose. So that in and of itself is shattering to the industry. So I think that this really falls into that category of a game changer. And we'll wait and see how the data will play out over the next few years.
Thank you so much, Scott. Thanks a lot. Nana, shall we?
Yep, we should move to, we're running out of time, to gene drive, but we don't have, yeah, but
yeah, we can skip
we can skip and go to vaccines.
And we'll come back to gene drive if there's time. Yes, so maybe we can listen a little bit to our other colleagues, to Mary and Kim.
Yeah.
And it would also be nice to actually bring back the other experts if they have comments to make on this. So just to open this up, Mary, there is 89 vaccines candidates for malaria, 153 clinical trials. It's amazing. As a PhD student, my professor bought for me Malaria Corpus, and the history of malaria vaccines, it's very, very long. Fortunately, we now have RTSS from 2021. Pedro wrote a fantastic opinion about this here. Historic vaccine, a little bit of imperfections, but a great start. You know, some comments about funding have been made here, and I think a good start would be just for you to describe briefly what the situation is with regard to malaria vaccines as a prevention tool that can be used in large scale. And really feel free to speak whichever angle you want to take it, and then we can bring in questions in that perspective. Back to you.
Yeah, it has been a long history, and that history is still being written, I would say. So where are we with malaria vaccines? Well, as you know, there's one that's recommended for use, RTSS AS01. It's still, in fact, in pilot introductions as well, because the pilots are finishing at the end of this year. The pilots are being conducted in Malawi, Kenya, and Ghana, and we have learned a tremendous amount from that about impact of a moderately effective vaccine for a high burden disease. Very high impact achieved. We've learned a lot about demand, and the communities, the government's really looking forward to this vaccine. In fact, Gavi has reported that there's unprecedented demand for the malaria vaccine. 13 countries coming in asking for funding support in that first window. We've learned a lot about something that Scott mentioned, which is manufacturing, and what happens when you have a product that does not have a dual market, and how that can lead to difficulties in sustainability and in supply. We've learned about the feasibility of delivering vaccines on an unusual schedule. RTSS is a 4-dose schedule given from 5 months of age. Unusual because most vaccines are given around 6, 10, 14 weeks, 9 months of age. And so there was some concern that parents wouldn't bring their children in for this vaccine, and therefore the impact that had been anticipated wouldn't be realized. But what we saw was rapid uptake of the vaccine in all 3 countries, reaching pretty high levels, certainly high levels of coverage for malaria control intervention. The vaccine now in use in these countries is resulting in about 25 to 30% reduction in severe malaria, resulting in hospitalization, and about a 10% drop in all-cause mortality in children age eligible for the disease, for the vaccine. And I think that really shows how much malaria is a factor in many child deaths in areas of high transmission. And this, of course, is on top of bed net use and other good malaria control measures in these countries. We're still, Scott had pointed out that this is not a vaccine for elimination. That's true. This is reducing burden in children, saving lives. And in a moment, I'll ask Lindsay Wu to talk about the vaccines on the horizon. but we are still learning quite a bit about how to improve vaccine efficacy, even with this vaccine. So we're seeing that maybe, or well, it seems that there is synergy when you combine the vaccine with SMC, for example, in areas of highly seasonal transmission, resulting in really high vaccine efficacy at that point, probably around 75%. We're wondering if you would get a similar improvement in efficacy if IPT or perennial malaria chemoprevention is combined with a vaccine, and we're looking forward to looking into that further. And we've found that you can have higher vaccine efficacy just by timing the vaccine differently in areas of highly seasonal transmission, giving the vaccine just before the high transmission season. I wonder if I can just share a slide that is not my slide. It's actually Paul Milligan's from London School. Let me see if I can do this. That really shows, it speaks to, can you see that now?
Yes.
Okay, it speaks to a comment that you made, Fedros, that countries are having to decide between one intervention and another, and of course that's absolutely not what WHO wants happening. It's not aligned with the foundation of subnational tailoring. We know that by layering interventions, this is where we're going to get higher and higher impact. So Paul Milligan showed this slide recently, looking at the data from different studies, different trials, and how you can layer the interventions to really push down malaria. Now, these are looking at data from highly seasonal transmission areas. He points out that you get about 45% efficacy with ITNs, with SMC, and I would say this could also be RTSS here because the study showed non-inferiority. So you can easily exchange these two, which have 60% added efficacy. You're pushing down malaria by 78% when you add those two. And then if you add the other, in this case, SMC, and you have ITN plus SMC plus RTSS, you're pushing malaria down 92%, by 92%. So we don't want countries to be deciding between ITNs and SMC or between ITNs and RTSS if we want to fully achieve our goals. And I'm going to stop sharing now. All right, and then I just wanted to—
Mary, if you don't mind, just to prod on that specific point. So is okay, so just clarification. So is this a wish or this is a recommendation?
The recommendation is that you continue with current malaria control interventions as you add on the malaria vaccine in areas of moderate to high transmission.
And that you are not deciding which one to drop and which one to bring in.
No.
Okay.
Now there's
Okay.
nor can speak
Okay.
to the subnational tailoring, right? That countries think about their own context, what they're able to scale up in their context as well, right?
Okay, go ahead. Sorry for interruption.
Yeah, but that's an important point. And moving forward on context, I just want to briefly touch on this point about accessibility that was mentioned earlier. And it's really, as we speak about research, we want to remember implementation research and the importance of understanding how to reach children with these interventions, how to get the highest coverage possible. Where do we reach a limit, because there are certain barriers that can't be surpassed. I just mentioned this way to get high efficacy with the malaria vaccine. by timing it just before the high transmission season. But we actually don't have a platform to provide the vaccine that way. It is through campaigns. We are giving vaccines right now seasonally, except flu vaccine, but that's not given in many African countries. So implementation research is also going to be a very important component so that our high efficacy interventions are also highly effective and the impact is realized. I'll say just a couple words. We are right now, WHO is in the process of reviewing the initial data on the R21 matrix M vaccine. That's the next vaccine candidate vaccine in clinical development. So we're looking forward to seeing what we find from those results. And if I may, I'll ask Lindsay Wu to speak a little bit about the second generation vaccines and other vaccines in the pipeline.
Thanks, Mary. Hi, I'm Lindsay Wu. I'm a technical officer in Global Malaria Program, but I work very closely with Mary's team that sits in the vaccines department. It would be great if you could go back to the slide of the pipeline, actually.
Of the pipeline for vaccines?
Yes.
All right.
Yes, that one. Thanks. I'm really happy you showed this. The WHO has been very active in tracking the malaria vaccine pipeline, and as part of a horizon scanning exercise to really have a long view of the R&D for vaccines. And I wanted to highlight something in particular when we developed this dashboard, which is available online for people to access, and they can play with the different categories to see, what is actually in the pipeline according to the different.
We got this by accident. You should promote it a little more.
Yes, we will.
Because there was one little reference to it in the WHO report. But
yeah, we're working on a report
to
to go alongside it.
All right, anyway, go ahead.
Yeah, no, I'm glad that you brought, I was going to share it if it wasn't included. But while it shows that there's been over 150 clinical trials and 89 candidates, I want to highlight that subcategory A, that only one vaccine has actually been WHO recommended and pre-qualified, which is, of course, RTSS. And if you go down to B, there's only one candidate in phase 3, which is the R21 matrix M. And so while there's been a really active pipeline, all of the candidates, of course, have reached very different levels of maturity. The WHO's role, we feel, is really how can we help to focus the R&D strategies? And so one of the major roles we play to do this is to convene the global community in vaccines research and try to help align the research community on what the major strategies and goals are. So what are the use case scenarios? And so the people we will involve will be everyone from the early stage developers that are developing the candidates to those who might be involved in the clinical trials, regulatory agencies or those involved in policy and regulatory, and of course the end users, national malaria control programs. And one thing we talk about is preferred product characteristics. So we actually publish a set of preferred product characteristics for the different use case scenarios we envision for vaccines. And preferred product characteristics are slightly different than what industry or funders might use in the target product profile, and that we're very interested in programmatic suitability. So not in addition to efficacy and safety, we're going to be thinking about how do we make sure that these products are accessible from a cost point of view, a supply point of view for LMICs, making sure it has the right route of administration, cold chain considerations to make sure we're really, from the early stage of R&D, developing products that are usable for the highest burden countries. Echoing what Scott actually mentioned earlier, our goals are to improve on the existing products, like Mary mentioned. How do we really use RTSS in different ways? But then looking forward, in order to really reach elimination, we will likely need not only multiple types of malaria interventions, but multiple types of vaccines, both from the perspective of the market as well as from a scientific perspective. RTSS and R21 are really targeting reduction of clinical burden. And if we want to progress towards elimination and eradication, we'll want to develop new innovative tools that improve on these. So game-changing innovations such as first, really improving that efficacy level at the pre-erythrocytic stage to the point where you can actually prevent infection, which by proxy would then reduce clinical burden in the blood stage. So we'll hopefully see more products that are pushing the boundary of this efficacy even higher than RTSS and R21. So we really want to encourage that R&D. Of course, you can also target other stages of the life cycle. So there will be vaccines in the pipeline that are targeting the blood stage, such as RH5, as well as transmission reducing vaccines like PFS25, PFS230 that are targeting gametocytes or the mosquito stages of the life cycle. And in addition to that, there have also been candidates targeting Vivax and Malaria pregnancy. And one area that's been very active discussion as well in the R&D community has been multi-target vaccines. So are there potential synergies when you combine either multiple targets in one vaccine or potentially co-administration of different types of vaccines that would address the pre-erythrocytic stage as well as the blood stage, for example? So if R21 and RH5, there's a trial that's planned to test those in combination. So the strategy there would be, if you combine a partially effective pre-erythrocytic vaccine with the blood stage could potentially be taking care of breakthrough infections that are not prevented by the pre-erythrocytic stage vaccine. Similarly, there's interest in combining the pre-erythrocytic vaccines with the transmission blocking candidates. So are there potential synergies in reducing clinical burden there? But then in addition, also targeting transmission reduction at the community level. So those are all of interest to us. And then I also wanted to speak a little bit about monoclonals. Alongside vaccines, WHO has also been monitoring the R&D very closely in monoclonals, and we've also been developing preferred product characteristics in that area. It mirrors a lot of the R&D path as vaccines, and that the leading candidates, as Scott mentioned, are targeting the CSP antigen. But there is, of course, target identification R&D going on for the entire life cycle as well. We're really interested in understanding when we talk about the use case scenarios, how these new products complement each other. So it's, again, not about product replacement. It's about how monoclonals fit alongside the strategy with vaccines and chemoprevention. And I'll mention as well the subnational tailoring. It's really, really important because how we use these interventions together will really depend on the different epidemiological profiles of the countries that are implementing, the cost and the delivery options, the health systems that are available. So I think we're very much aligned with the other speakers in how we view all of these interventions as a package.
Thank you very much, Lindsay, and also Mary. So just two very two other questions on RTSS. In the pipeline, you also mentioned in the development you talk about R21 as well, but you didn't mention anything about comparing the first line vaccine with the second line vaccine. Is the comparison trials ongoing?
Currently, there is not a comparison of either RTSS to R21 or either of them to second line, unless if Lindsay, the R21, R5 has a comparison arm of just R21 matrix M.
I think so, but I'm not sure actually.
Yeah. So,
but if in case there is maybe if you guys want to comment on that, or if any other experts want to comment on not necessarily the comparison with efficacy, but just how these two vaccines, how similar are they, how different are they, expectations.
Yeah, it's
we
very.
have a slide in the deck. Just can use that. Go ahead.
Yeah, that too.
Sure, you can put up the slide if you have it. You have a slide.
No, just for our audience to understand what the differences are between the two vaccines.
And between RTSS and R21. They're both pre-erythrocytic vaccines. They're both targeting the same, the sporozoid, or the entry of the sporozoid into the liver cell. So the same stage of the malaria parasite. There is no head-to-head comparison. And another thing we've learned in the last few years, which has been extremely important, is that without a head-to-head comparison, it's hard to compare efficacy of two vaccines. And this is because efficacy it differs by different contexts. And that's very odd. It's not what we usually think of with vaccines. But we now know that with RTSS, there was higher efficacy when the vaccine was given in low transmission areas. It has very high efficacy if you have low transmission. It was 80% efficacious at a year in Khalifi, very little waning over time. You only need 3 doses. But that's not where the burden of malaria is. And so it's not actually recommended for low transmission areas. And then at 1 year in the areas of moderate to high transmission, the efficacy was 55%. So if you have vaccines that are being tested in different contexts, and even the number of sites, if you have low transmission sites represented more than high transmission sites, you might have a different efficacy than if you had done it differently. And we know that you have different efficacy if you give the vaccine seasonally, as I mentioned, so the timing of the vaccine according to seasonal peaks. So at this point, we're just looking at the data. It would be hard to say if one is more efficacious than the other without a head-to-head trial. But what we do know is for both, it seems, I mean, we're still looking at R21, but we expect that the results will show that for both, they would be worthwhile, have impact. And I think it's becoming clear that to get highest impact, delivering just before peak seasons increases efficacy, but we would have to know it could reach children that way. And that's for both vaccines.
And then one other very last question, Mary, is so for RTSs now, there's a very high demand, like you mentioned, and then the supply is really low.
Yeah.
So there's a framework now for how to allocate the vaccines. Can you tell us a little bit about that, please?
Yeah, thanks for that. So the demand is even higher than we had anticipated. And perhaps this has to do with the high impact that was seen in the pilots, or just countries seeing malaria continuing to be a major cause of mortality in their children. So there are 18 million doses available right now between 2023 and 2025. The first countries outside of the pilot areas will start implementing the vaccine at the end of this year. Now, if there are some countries that could use up all of that vaccine supply if this was just done on a first come, first serve basis. Some large countries could essentially absorb all of it. We know that WHO has committed to support the continuation of vaccination in the pilot countries. So those areas will continue to provide vaccine to the children. And that's just a basic principle about vaccinations. You don't stop a program if you've started it. So anticipating this, WHO convened a group of experts, mostly from the African continent, because that's where the largest burden is. And we asked them to help develop a framework for how to deliver, how to allocate these limited doses of vaccine in these first few years until vaccine supply increases, so that there's not a gap in supply and demand. And with their guidance, this framework was developed. It's based on ethical principles for allocation and lies on a foundation value of solidarity. And what, in brief, what was recommended in WHO and Gavi and UNICEF are following is that the first priority principle is that the limited vaccine doses should go to areas where children are in highest need, meaning they're at highest risk of malaria, illness, and death across countries. So it means that in each country that wants to introduce the vaccine, they will have to start with what we call this category 1 area, where malaria burden is extremely high and mortality is high. And then with time, they would expand their subnational allocation and expand to other areas of the country as supply increases. So what's happened with this is that already at least 28 countries have said that they want to introduce the vaccine in the coming years. As I mentioned, 13 already submitted applications to Gavi to be able to introduce in 2023 or 2024. This purple, that was a nice slide actually. The purple are the category 1 area. So you can see in almost all cases, it's subnational areas. And then as supply increases, either through the ongoing tech transfer to biotech of RTSS, so that the supply of RTSS can increase, or through the second and maybe third or fourth vaccines coming forward in the coming years, then the vaccine can reach children in broader areas throughout the moderate to high transmission areas in Africa and a few areas outside of Africa as well.
Thank you very much, Mary. I think Scott, your hand's up for a while.
No, thanks. I wanted to go back. I think, while I very importantly tried to make the point that the monoclonal antibodies are a drug and therefore obviously can be used to provide immediate protection, for example, for people who can't get a good response to the vaccine. I didn't really emphasize that before, but I think Lindsay made an important point. The other thing that monoclonals can do is to help us figure out and to validate new targets to make a multi-target vaccine. And I think as we go forward in the future, we will see a lot of interplay on how to make vaccines better by what we learn from the monoclonal antibodies. So I think for this group, as we're thinking about this going forward, as you heard, we're starting on a few targets, but I think this will be a big area of future research on how we can make better vaccines from what we learned from the monoclonal antibodies, because the vaccine responses are much more complex than just by, with the monoclonal, we can answer some of those questions about combining things that can then be put into making a better vaccine. So I think in the future, you'll continue to see a close interplay and dialogue between these two types of technologies.
Petrus, I think we're running out of time and there's much we would like to talk about.
Yeah. So do you want us to move on?
I think so. There's just one other bit perhaps to get Kim on, but we might leave it for later on, because with what we've learned with RTSS, knowing that it was a vaccine coming up, this was going to be very positive. And then we now have it, and then we face a situation with supply and demand, perhaps with other products coming out too. Maybe we should have that in the planning of how we're going to manage that scaling up. Or we can bring that later on when we get into implementation and operational. So Frederick, go ahead.
All right. So thank you all for that. This has been an excellent conversation on the different products, and I just want to say also we are hoping that the rest of our experts can be jumping in, either addressing the questions on the chat if they feel like they have the answers for that, or just jumping in and making conversations with us. We still have a number of questions, but only 1 hour to go, so we will try and race through time as well. One of the points that we wanted to highlight is during COVID, there was a lot of talk about mRNA vaccine. I just want to throw this out there just in case one of our experts want to make a comment on that. Towards the end of last year, we've had this publication on using the lipid nanoparticles to express PF-CSP and PF-CSP vaccine candidates. We thought this was really interesting, appears to be a fairly significant progress in that direction. So again, any comment from our experts would be appreciated. Perhaps, Nana, we should move to anti-malarial therapy, so speak a little bit with our MMV colleagues.
Yeah.
No, excellent. So we are lucky to have with us our MMV colleagues here. We had actually maybe 2 years ago a dedicated masterclass with just MMV, and that was excellent. But today they are joining us to talk about malaria therapies here, and maybe Nana, I bring it back to you actually to begin that conversation.
Okay, so yes, so we saw this media update, Novartis MMV, and with David Reddy, and in there we have the first medicine that I am not missing in, and that's the I'm losing the name now, Pyromax. Perhaps
it's actually not Pyromax. It's a
seasonal malaria chemo prevention.
Exactly. So, George, can you come in now to tell us?
Sure. Happy to jump in. And sorry for being late. I had to watch you guys on YouTube because there were over 300 people. It was amazing. So I was blocked out. Congratulations on an amazing masterclass. So now that people are dropping off, I was able to come in about an hour ago. No, listen, Viveka's with me, and she actually worked with Noor on trying to crystallize the R&D pipeline that's relevant for some of this discussion in really with the 5 to 7, 10-year timeline. I work in the access space, so I'm actually not in the R&D team at MMV, but I can pick up a little bit on that messaging that came out through David's tweet on SMC. But I actually wanted to use that as a response or something Pedro's comment a way back. I think about an hour ago, Pedro did post a comment that, let's not forget that the fire burning super bright and out of control is in the highly endemic countries. And he said, it's not just like we're holding still, we're sliding backwards. He talks about significant increases in malaria cases and deaths, and that's real. So I guess there's a firefighter's response today and for the coming years. And then there's the ultimate extinguishing of the fire, which we have to be planning for. And we all agree it's going to take different tools. But I do think in this 5-year time frame, that's sort of the time frame I restrict my thinking to, because when I'm talking with malaria programs, with implementing partners, it doesn't really help them get on with the job to be thinking around, vaccines they might see in 6-7 years. Someone needs to be thinking about it in national programmatic capacity, but year-to-year planning and working with the cycles of funding they have to work with, which is where the rubber hits the road, or frankly, it's where the handcuffs come on in terms of what they can't do, then I think there's a lot to think about in terms of that sort of cage rattling that Pedro did. In a 3 to 5 year timeline, what can we do that maybe the question of elimination being farther out, but that really contributes to reducing malaria deaths? We're going to be at 0 malaria deaths for years, maybe decades before we talk about eradication or elimination. So how do we get the 600,000 number dropping down again instead of staying flat or going up? And I think really it's part of that is maximizing the space that we've still left on the table with existing tools. And sometimes it seems very non-glamorous, but I think the impact can be massive. So just 2 quick examples, and then I'll let Viveka talk more about the future vision. Right now, the chemo prevention flag that you brought up, the quote about 46 million, that's an estimate about the number of kids who were protected last year. SMC is not perfect. You've seen some of the comparative and contributory effects that it could have combined with vaccine, but on its own, even if we're talking about knocking down malaria admissions to hospitals, severe malaria admissions by 50% in some countries, it's a very cost-effective, very ubiquitous, and very scalable intervention. Something that wasn't always believed in 2013 when it started to take off. Seen as a vertical program, it was going to be difficult, acceptance would be challenging, and yet, you know what? Sometimes it's good to be wrong, because those who were skeptical have found out that, wow, it really did take off and has stayed at a very high level of acceptance, and country desire to expand in probably 3 ways: their own geographical reach in countries, the amount of duration of coverage. So it's not just restricted. And I think Pedro worked on this very hard when he was in GMP. Say we don't have to do it for 4 months because that's what the clinical work showed. Adapt it to your realities. So that's something countries are now empowering themselves to adjust it. If they need 5 months, they're going to 5 months. And then the last thing is countries where they have seen and measured an increase or an expansion of the age range where they're seeing malaria creeping up where normally they would expect it to be dropping off. They have chosen in a couple of pioneer countries to expand the use of that tool for kids up to 10 years old. So this isn't glamorous work. It's the same product, but being used intelligently by countries adapted to their local realities. And the impact could be quite massive. I think it already is, and it will grow. And then the second thing that's also an incremental improvement, but also very exciting in the drug space, is how in the last year, the envelope has been pushed for expanding protection to groups that were basically left to, I would call them imperfect protection or imperfect treatment options. The use of ACTs, or at least the ACT artemether lumefantrine, AL, and the first trimester of pregnancy has been a long time coming. The evidence wasn't fully baked. There were a lot of things that still needed to be considered, but now it is baked and the evidence is in. The WHO position is clear, and there's more to be done with other ACTs. But that makes a big difference for any woman who comes down with malaria in the first trimester of pregnancy. I think it's transformative for them. The numbers might not be in the tens of millions, but for that group of patients, it's a huge step forward. And so I think, in the R&D space, we look big and we also look the short game. And so I'll stop here and see if Rebecca wants to maybe round this out a little bit more with the long game. But I don't want to underemphasize how important it is for the next 3 to 5 years to really keep improving on what we've got in our hands. Thanks.
Mm-hmm. Thank you, George. I'm feeling a little old-fashioned here talking about drugs since we were talking about shiny new tools. But I think there's still quite a bit to do in the drug space. And starting with the very exciting news that we announced with our partner Novartis of moving ganaplacide lumefantrine into phase 3. So this would be the first non-artemisinin-based combination therapy, right? So clearly an advance on resistance preparedness. It will still be a 3-day, once daily combination therapy. We're still a few years away.
Sorry to interrupt. How do you pronounce the name, by the way?
Ganaplacide lumefantrine. We should not get too used to that name because it will obviously change as we approach registration. So it will have a fancy new name one day, hopefully. Yes, so the drug space is all about incremental improvements, right? So we'd like to, with each combination that we bring to market, needs to do something better and different than the previous one. So this will be the first non-ACT, which sets the bar for everything that follows. But then we think about from the patient perspective. So this is a 3-day. Do we have a chance in the pipeline to develop something that's twice 2-day therapy or single dose cure, which would be the ideal for elimination purposes? So then our pipeline is set to test 2 other combinations in phase 2, starting this year. And again, it's still a build on an old and a new drug. So lumefantrine, as you know, it's the same as part of AL, except it's been reformulated, so it can be given once daily. We also have still ferroquine, an old 4-aminoquinoline that has the longest half-life of all drugs known in the pipeline. So it could be useful because duration of activity is also very important for the patient. And we're going to combine that with a new molecule in partnership with Zydus, and also pyronaridine, which is in the combination with artesunate and Pyramex. But it is a very well-known molecule, probably as safe from the preclinical perspective in pregnancy as anything else that we have in the pipeline. So combining that with a novel molecule in combination with Merck, that could also give us potentially a shorter duration of treatment, and then move away also from lumefantrine, a partner drug that concerns are rising about resistance as well. And so beyond that, then we have a number of exciting molecules in phase 1 development. And then we can start thinking about adding those on to triple combinations. So this mixing and matching and multiple drugs is quite common in other infectious diseases. In malaria, we stuck very much to 2 drugs. But I think the field is opening up now to adding a third component if it's going to get us somewhere to the target, right? If it's going to reduce the number of dosages required or gives protection to pregnant women, children still. So as I said, each combination that we bring to development has to do something better than the previous one. So that's for treatment. And I think it was a really nice slide that you had shown at the very beginning, that we should not forget that drug development is really, it's a numbers game in a way. The probability of success is so low, right? When you start from phase 1, maybe 10%. And then it increases obviously as you gain data and confidence. But it has to be a relatively big pipeline to start with because of the time that it takes and the varying probability of success. So that's all I think I should say about treatment space. And very quickly about chemoprevention. We were talking about the cost, which I believe, Scott, that hopefully it will not be an issue. But we should also not forget that drugs probably are still cheaper in some ways, or easier to get to the target pricing. So we've been investigating a bit in the arena of long-acting injectables. It's the patients are probably going to be used to injecting treatments, so vaccines, monoclonals. Why not drugs? For the longest time, we thought that oral would be preferred, but once we started talking to people in the field, there seemed to be actually readiness to accept injectable drugs. And there we are doing some work in reformulating, again, an old friend, atovaquone, which is part of Malaron, but in an injectable form with a new class, another ELQ family of molecules. And the concept would be to protect patients for probably, if we can stretch it to 3 months, that would be ideal. So that's fairly early work, but cost should be an easier target to reach, and hopefully patient acceptability would be there as well. And in chemoprevention space, we can also think about remixing some of the older drugs in combinations, for example, long-acting drugs like pyronaridine and piperequine, to see if we can extend, their utility and move into the prevention space. So I think I'll stop here unless there are specific questions. Over.
Thank you. Thank you. I think perhaps there's one more thing we haven't touched base is the coverage. So you talked a little bit about cost and in terms of the production itself, and there's this other bit which is the other side of the coin of getting these drugs to the people who need them and to the most vulnerable. And we know that issue in the health systems and the whole issue surrounding community health workers, which is backbone really of reaching universal health coverage. So sustaining and the scale up is also part of it. Georgia, your hands up.
Yeah, thanks for that. You brought up a great point. I think I alluded just in passing to the real constraints that countries unfortunately are having to make. I'd like to say less and less, but I think more and more in some ways with current global fund constraints they're facing, trade-offs they have to make. Therefore, as a form of research, it's not in the laboratory, but it's certainly out in the field. The support countries can get in the coming years to really understand the best clinical outcomes they can get from combinations. So again, going back to what Mary showed us, how the vaccines and And we hope one day the monoclonal antibodies will be interfacing with medicines. That's important. And then the science of operational research. So right now, when we think about the world of SMC, we visualize this community-delivered monthly intervention, and about as far down in many countries as you can go in touching patients, or not patients, touching people you're trying to protect. And then we layer onto that what a concomitant strategy will be with vaccination. And if you think of it as going down a pyramid, then suddenly you're up like several more layers in the delivery system, because the same people going door to door reinforcing the monthly SMC regimen are most of the time not the same people who are going to be doing 3 vaccinations at month 5, 6, and 7, and then coming back next year. They're not going to be in most cases. So that means then we think about somewhere up higher in the health system, there will be a concomitant strategy. And maybe, I mean, these are the things that are really wide open to trying to figure out what the adapted integration of these tools will look like in real settings. And we're excited by it. All of us should be, but it's also daunting because it's completely greenfield. No one has a perfect beat on that. The work that was done by the London School team with African counterparts in that combined research on RTSS and SMC is really exciting, but they weren't trying to solve the question, and what will it look like deployed on a large scale? So let's remember that getting some of those things worked out earlier than later. So by the time we do get past the very limited RTSS production, so maybe in 8 years or 6 years, whenever Bharat starts to produce a lot of RTSS, or when R21 comes out in the tens and hundreds of millions, not the single millions of vaccines, let's be ready to help countries figure out what deployment can look like. They'll have to lead the charge on it, but I do think from a support basis, that's a really important research question. Thanks. And money matters, huh? So to be very clear, it's $3 to $5 a year for a total course of SMC protection, and UNICEF says it's $38 a year or over 18 months for RTSS protection. Countries have to deal with that, right? We can't just pretend that's not a very stark reality that they're facing. They will face that, and so we need to be keeping that in mind. Thanks.
Right, just over to you. I think we should move to.
No, thanks a lot to our MMV colleagues. There are questions that emanate from this, which I think our other experts can take as well. These are questions to do with drug resistance, and we don't have to pick them up here. We can take them later. If let me just close the door, my son is awake. We can pick them up if we have time. So if you don't mind, maybe we just move to speak to our colleague from FIND for now. Is that okay, Nana?
Sure.
Excellent. So thank you so much again, and hopefully we can come back to the questions about drug resistance, because I think that is really, really important as we prepare going forward. So earlier on, we had a conversation with our colleagues from FIND, and I just would like us to bring them back a little bit, if that's okay. Again, just for them to one more time talk about how they are supporting these sustainable and resilient health ecosystems, how this relates to not just case management, but also trials for malaria products. I think that would be really, really nice, focusing more on the diagnostics. One other piece that would be nice to hear from our FIND colleagues is whether they are in any way engaged with the innovations for diagnostics for in the cases of HRP2 gene deletions, which is also spreading quite a lot in Africa. So come on in, please, just speak to us.
Hey, so just as a quick kind of intro to FIND, just for people who may not know what we are, but so we're a product development partnership with a real focus on ensuring that diagnosis, which is, as everyone I hope would agree, the foundation of good case management, well-informed case management. You can't treat someone appropriately without knowing what disease they have, as well as the foundation of good data for understanding the burden of disease, so as to allow programs to allocate their resources appropriately. So yeah, a key part of the data piece that's been discussed a lot today. So if you go to the next slide. So FIND itself is PDP with offices now in 5 different countries. We were established 20 years ago, and are focusing on a number of different infectious and non-communicable diseases as well. Are a WHO collaborating centre, and use that to really kind of play a role in evaluating different products which are available as part of, sort of quality assurance systems, to try to support sort of informed decision making and procurement by countries. Do you go to the next slide?
Let's see.
Okay, that's what you had. That was fine. So
No,
yeah,
we have some.
No, that's fine. That's fine. I mean, we've covered a lot of the intro anyway.
Go ahead. Yeah.
But essentially, you know, there are kind of quite exciting technological advances taking place now through COVID. You know, off the back of COVID, that huge investment that went in, and some of that tech now can be kind of re-leveraged and repurposed for diseases like malaria. So that is ongoing and provides some kind of good opportunities off the back of that. So yeah, so just the way the model that FIND has, essentially we're the small little cogs that try to get the big different players talking to each other and working right across the diagnostics pipeline to try to ensure that the diagnostic technology, the diagnostic tools which are available are sort of fit for purpose in the places where they need to be. And so we have work ongoing with R&D, product evaluations, and generating evidence for product registration and PQ submissions, pre-qualification. Working with manufacturing to try to ensure that diagnostics are available, you know, from a resilient and robust number of suppliers, and increasingly that means a shift away from sort of large manufacturing capacity outside endemic areas, and now trying to establish that within endemic areas. Procurement to supply chain support, advocacy and awareness. So there's been a lot of chat in the group, the chat today about advocacy and community engagement particularly. And I think, yeah, like one of the kind of striking data points that comes out of the malaria report this year is that, as always, the level of treatment seeking for young children, febrile children under 5, isn't as high as where we'd like it to be. So I think the estimate last year was 67% of kids with who are febrile actually going and being taken for treatment. And of those, about 2/3, 57%, are then receiving a test for their febrile condition. So while that's ideal, it's actually a really good improvement since pre-2010, when it was only half the number who were actually receiving a test. So there have been improvements in trying to engage and promote treatment seeking, but I fully agree that that's a huge piece that can't be met just by improving the R&D on its own, and fitting it into the community landscape and partnership is key. So yeah, so these are some of the kind of high-level technological advances which are ongoing at the moment, and these are across diagnostics overall, so both communicable and non-communicable diseases, and we're trying to see sort of how some of that tech can now be applied to malaria diagnostics specifically. So yeah, I mean, we can give some specific examples. So mobile devices and connectivity, I think, again, feeds nicely into the discussion around data, surveillance, and trying to ensure that RDT results are being interpreted and anti-malarials are really being given just for patients who have a confirmed infection. And then there's a lot of work going on. Maybe do you want to now talk about HRP2 deletions as one of the big threats?
Yes, yes, it would be really nice if you guys have any information on this. And I mean, at the moment, as it stands, there is no pre-qualified. I might be wrong. I hope I hope that's correct. That there is no diagnostic pre-qualified for distinguishing between P. vivax and P. vale, number one, and number two, that we have all this huge challenge with HRP2 gene deletions, and we have a WHO guidelines that request countries to change the diagnostic test once you exceed 5%, and that means people really need an alternative. And so in both those two scenarios, what exactly is in the pipeline? If you could talk about that a little bit, or maybe if there are other experts in the team who would like to talk about this as well.
Yeah, sure. I can take the HRP2 piece, and then Kevin, maybe you can pick up after that. I saw you had the map of the WHO's threat map,
right, yeah.
One of the slides. That will be a nice one to bring up. So back in 2010, I think, parasites in patients in Peru were being found to be testing negative by RDT, but were positive for malaria, for falciparum malaria by microscopy. And so work done to kind of follow up on this observation identified a gene deletion in those parasites that meant that they were no longer, the parasites were no longer expressing the HRP2 protein and its homologue HRP3, which is very closely related and will also react with the HRP2 diagnostics. And to this day, HRP2 based diagnostics remain the main diagnostic used for malaria. I think it's something like 80% of diagnostics procured through public funding mechanisms are based on HRP2 detection alone. And so the spread of these parasites, which will be testing false negative on these diagnostics, is really concerning. And so this map here is an effort by WHO to try to bring together all the evidence of surveys looking for these big threats, which potentially undermining our frontline diagnostic capabilities. And so the red points show surveys conducted. I think this goes back to kind of early 2000s. I can't remember the exact time window, but you can kind of select, filter different criteria that you're interested in if you go to the site. And essentially the red points show any evidence of documented deletions. One thing that's important to note is that this doesn't give you any indication of prevalence. This is just occurrence. And there's a huge range of prevalence within this map. So for example, Eritrea and other parts of the Horn of Africa, we're seeing rates of up to 80%. So clearly there's a massive need to bring in alternative diagnostics. And so FIND and PATH and others have been evaluating new diagnostics which are being developed to address exactly this problem. And the solution that's been followed, taken for the time being, is to try to improve LDH detection. So this is the other main biomarker that's been used so far in RDTs. Historically, though, its sensitivity hasn't been as good as HRP2. And so these manufacturers are working hard to try to improve that and try to come up with an RDT that can detect both falciparum and vivax, but in the context of these deletions, we're thinking specifically about falciparum infections with the deletions. And so those studies are ongoing and nearly finished, and some of the diagnostics have already been submitted to WHO pre-qualification. and others I think are expected in the coming months. So on that note, I think there's a lot of hope for some next generation tests to try to address this major threat.
Thank you.
Did you want to
Thank you so much.
Did you want me to, I'll probably be repeating what I said beforehand, but did you want me to say a bit more about what we think of doing in terms of the diagnostic space? Okay, so as I touched on before, a lot of what we're driving now, and Roz has given you that overview of what we see our role as in terms of facilitating and supporting market entry for new diagnostics. We're also very much involved at some of the earlier phases where we try and discuss the needs of the diagnostics in particular settings. And I think an hour or two ago, someone had mentioned the idea about using targeted approaches depending on the use case setting for the particular country or particular geographic region. And so when you're looking at that sort of context, that's something that's quite important taking forward when you start looking about these types of diagnostic approaches. So not everything we're thinking of doing will apply everywhere, but we are trying to look at it in the kind of context that the applicability, the sustainability, the access to these new diagnostics is much more broadly applicable, so that we're in a situation where we can launch these tools and use them in the setting and in the way that they're intended. The other thing I'd like to touch on is one of surveillance. And the idea is that with some of these new tools, once we have them in place, they will also serve as a kind of sort of data gathering exercise to generate exposure patterns where prevalence of disease, when we're moving in areas towards elimination, then it'll give you an idea as to what's happening in that area. And of course, then you can target the next round of intervention that's required, because obviously, as you start to get lower and lower in terms of transmission, then you need to bring different tools to bear to be able to capture that remaining bit of infection. If we are going to go straight, try and push for zero malaria, then you need to change the tools that you have. So the idea and the things that we're thinking about are very much with our eye on that particular prize, that we have a short-term goal that we need to achieve, and with the reduction of deaths and really try and get some engagement with the public healthcare systems. We want that medium goal where we've got that long-term sustainability, so we don't have to start thinking in 5 years' time that we need to change that whole strategy that we've helped deploy. And then that long-term goal where we're thinking that that data we're generating is building a vast amount of data that we can then use in a way to guide a more sustainable engagement, a more sustainable reduction in infection. I guess when I'm talking about surveillance, I guess I could touch a little bit on molecular surveillance, which is the kind of thing that there's a lot of information out there, there's a lot of data out there, and we kind of think it would be there's a lot being done already, and we would like to engage with that to try and see how we might be able to use that information to support the kind of diagnostic interventions that we're trying to do. And I think with what Rosa touched on before about this situation with HRP2, HRP3, in order to be able to stay ahead of that and to be able to still be able to use the tools that are relevant in particular settings, is if we understand what that molecular signature is in one particular setting, we know what tools are going to work and what not, and we can swap around and shift things around in quite the way has been done for some of the deployment of drugs, where if the drug's no longer efficacious in one area, you swap it out and give it a chance for that particular mutation to disappear. Kind of moving into areas which aren't really my strength now, so I'll probably stop talking before I get myself into trouble. I hope that answered your question, was after what you were after.
Yes, Nana, go ahead.
You're on mute, Nana.
That covers, Kevin.
Thank you.
Hold on, just Fedros, what should we do now? Should we?
I think we can draw to close. I see we have only 15 minutes left,
Yeah.
and I would love us to just discuss the funding question, and then we can close. Because we can't finish. If anybody needs the slides deck, we can send that out for our participants who would like to see that, because we won't be able to finish. But it would be nice to discuss a little bit with the financing situation. I hope that We still have many of our experts in the house. Kimberly, it would be really nice to hear your voice here if you're still around. Tom, if you're still around. Absalam Noor, if you're still around, would be great, and Scott as well. And this is really how we want to start it. So we were looking for $7.3 billion in 2021. We got only 3.5 billion. This target keeps moving. For a long time we thought it was 6.5, and then it was 7, and it's going to be $10 billion needed very soon. The other thing that is likely to happen is that the commodity prices will start rising, especially as we start to have new products that are either against resistance and therefore more expensive, or as the markets take their own shape. Some of these commodity prices have gone down a lot because of increased procurement, increased demand, but at some point the prices are gonna go up. And yet, as you can see from this map, these are graphs from Cohen's paper. You see that there's not been any significant increase in the past 10 years. What would be really nice to hear from all our experts, and we can go around to hear from each one, is really how do we, two things. Number one is how do we actually bridge that gap? And number two, what are some of the efficiency gains that we can make in the context of limited amount of money that we have, or do we just give up and say we don't have money? So, the replenishment gave us 15.7 billion. We needed 18 billion. All the countries and Global Fund cannot cover everything that they need. So it would be really nice to hear from you all. We start with you, Tom. I would like to hear from Kim as well, then Scott, then Mary, then Roslyn, then everybody else, as we go like that. And Nana says that there are very interesting questions on the chat as well that she would like to bring up, at least one, and then we can bring this to a close. So we start with you, Tom.
Thank you very much, Fredros, and I'm sure all of us here are equally interested in this question. And the challenge is that we have this great pipeline of things, and it's very clear that we're not going to be able to do all of them everywhere, and we're going to have to make choices about it. So I think the first thing we must recognize is that we should embrace choice and decide that we have to work out a way to do that. And as Pedro said earlier on, there isn't a consistent set of data that would support anybody making any choices at the moment, and that we're going to need much more granular, locally relevant data about optimizing the choices that people make. It's not even clear that we really agree what the right parameter to optimize on is yet. So I think that there's some important work to be done about that. So we think that the first thing to do is to improve the methods that we use to make those choices, and to invest some of the money that we have in gathering that data. A second thing that we are very interested in IVCC is to pick up on a trend that we see, particularly in sub-Saharan Africa these days, in which other partners have become very interested in supporting improvements in health, not just in malaria, but across a wide variety of problems in their countries, and in which public-private partnerships between the ministries of health or malaria control programs and big organizations who serve a large number of people or rely on a large number of people. So these might be big industrial partners, for example, mines or plantations. They might be other kind of groupings, faith-based groups or hospitals or education systems, people who have a large population to address, collaborate with the malaria control campaign in the implementation of programs, and are often very efficient at doing so because they know their local population, they know what products work for them and what products they like to have, and are able to serve those populations very effectively. So we are looking for ways to increase their participation to help them to understand the benefits that can accrue to those organizations from this. For example, we had a wonderful case study from a hospital in Malawi who were able to demonstrate that by investing in vector control, they actually reduced their malaria costs, because they went from being half the year with the hospital just completely full of malaria patients to a case where they had very few malaria patients, and they were able therefore to spend the money that they saved on that, partly do vector control, partly doing the rest of the medical things that they wanted to do. So,
and is this a private sector funded?
It was a charitably funded. They were funded originally by the Rotarians, but I think a number of other faith-based groups had participated there. So they're helping funding organizations and the control campaigns to understand that actually sometimes spending money on malaria is a highly cost-effective thing to do, can contribute towards that. So I think that's my second step is engaging public-private partnerships. And the third step, I think, is about doing things more efficiently. That we quite often see big variations in the costs of implementation, and there could be value in learning how to implement our malaria control systems in the most effective way, so that it cost effectively reaches the maximum number of people. So, for example, I talked earlier on about the targeted sugar baits. It would be really nice if, when those arrived out of the epidemiological trials, we were able to find a way in which those could be distributed and implemented in a very highly cost-effective way. If you look at the product, we look at it and think there is no reason why this should not be implemented by the householder themselves. No reason to have it be as expensive as IRS and have teams of people out mounting these things. And we would really welcome the opportunity to do the operational research to show how those things can be implemented really cost effectively. Now, I'm going to stop there.
Thank you. Thank you so much, Tom. Nana, whom do you go to next? Is Kim on the line? Anyone else?
Had to drop.
All right.
Because we really wanted, would have been good for her to continue on the operational research and implementation science part of thing, which we haven't had much time to talk about that, but we will organize a class for that. It's equally important.
All right. Any other experts?
Can I come in here?
Go ahead.
Yes, please, Mary.
I really appreciate what Tom just said, and I just want to add to it or expand on it, and the idea of optimizing what we're doing. In the case of vaccines, what we're seeing in the pilot countries during the time of COVID, where coverage of other vaccines slipped, it didn't in the areas where the pilot was conducted. So why was that? Well, we don't know. I mean, we need more data on all of this, but we do know that there's very high demand for this malaria vaccine. We know that parents are coming in, and there's the opportunity to now reverse some of the backsliding that's happened in vaccines, to reach these children with the vaccines they've missed, to reach them with bed nets. So part of using the tools we have and the contacts we have in a more efficient way, which reduces the cost of those. And then the second point, again, Tom had made as well about reaching new partners. And I think that that's really key. And with all the exciting things happening right now, I thought this was an incredibly motivating and encouraging discussion today. All the exciting research and development right now in malaria. I expect that some groups that have not been so involved in malaria in the past would find this a very important area to start engaging in. As countries that are affected have more robust, as they have improvements in their own economies, they may be able to contribute more as well. Just a few comments.
Thank you very much, Mary. I think there's one. Yeah, Tom. Kevin, did you want to add?
I think someone's got their hand up, so I would go with those. The only thing I would say very quickly is just an appreciation for the tools that we do have and how best to use them, because it's great to have some new stuff coming through. But I think understanding what we have, how best to use them, will guide what we do with the new tools that come down later down the line. I'll hand over to someone else now.
Thank you very much. So we've got Abdullah. Will let you come in, but I wanted to finish with Scott and Noor. Are you still there as well? So Scott, can you go ahead?
Sure. So first of all, wonderful discussion, and I agree certainly with the funding comments from my colleagues. I think the one thing I would add, and this is maybe from having worked in the funding space for 7 years, I do think in the long run, we do need to build out a funding mechanism for elimination and implementation research for elimination that is fenced separately from the ongoing significant needs of implementation research and new tools for malaria control. I think where we have blended this, as Pedro summed up at the beginning very nicely, there's kind of an envelope that's fixed. So bringing in new tools that are more expensive is not really an answer. But for elimination, I think hopefully we've convinced you we do need new tools. So I think we do need to find a commitment from funders for specific elimination implementation research and R&D that right now is basically being carved out of that current envelope for control. So I know these discussions are going on. It is hard to make that argument until you actually have some exciting elimination tools, because if we basically say we don't have the tools we need for elimination, why would people want to fund the elimination focused effort? So the timing is important on this, but I think this will be an ongoing important dialogue over the next 5 to 10 years, as I hope we'll see elimination focused tools and then figuring out how to best implement them to continue to make progress.
Thank you, Scott.
Scott, are you proposing a separate fund for R&D vis-a-vis elimination?
No, I would not separate R&D from I think that whole spectrum, that end-to-end spectrum from R&D through implementation research and actually execution and elimination in countries going forward. I think we've integrated it with the countries that are currently working on elimination today. I think maybe because we've been able to do it with current tools. I think in the future, we are going to have to separate out elimination from control. So I think this will be, as I said, a dialogue. I don't think there's a clear pathway forward to do it, but down the road, whether it's for gene drive, whether it's for elimination, targeted efforts using vaccines and drugs and so forth, carving that out of our existing envelope for malaria control is a challenge.
Nana, back to you.
Abdullah, I think we'll end with Tom, and Noor is not responding. So Abdullah, can you intervene? I'm not sure if I'm pronouncing properly.
Oh, Noor is back.
I was here all along. I was just waiting to give others the time to speak. I have 20 minutes to present.
Yeah, we are looking for your comments on the money, So where's the money, my friend?
I think it's actually one of those things that potentially requires, there are three things that potentially require separate masterclasses. One is on funding. The other one is innovations and implementation. And one that's close to my heart is innovations in surveillance. So I suggest you think about those things, because the questions you're asking are really big, really fundamental. They could range from the really kind of big geopolitical issues, which is a fair trade arrangement that allows low-income countries to get the best value for their products so that they have the national revenues to respond to threats such as malaria, all the way to how do we divvy up the little bit of money that largely comes from donor agencies. And that's a discussion that requires not just us, it requires development economists, it requires health economists, it requires others who are best placed to address that question. My feedback, quick feedback would be, there is a tendency in the malaria community to either say we need more resources or say we need to do more with less, yet it's actually one and the same thing. If only you can demonstrate that you are able to do the best you can with what you have, that's probably your most important advocacy tool for getting more money. Unfortunately, we are divided on the narrative. And I think if I can say one thing around the funding issue, which is linked to implementation, is for us as a community to come together to understand that there's really no separation between needing more money, which is always the case, and doing more with what we have.
Excellent. Tom?
Well, we are really at time, so if I may add very quickly one final thought. For us, from the vector control perspective and our ability to bring through new tools, as well as all of this discussion about money and the selection processes and all of those things, one more thing would really help us. And that is clarity and confidence in the process whereby new tools come through the development process and through the process of qualification and listing and policy creation. Because at the moment, that process is slow and uncertain. And that is very frightening for our industrial partners. And I have to pay great respect to our industrial partners, people like BASF and Sumitomo, Syngenta, Bayer. And I see Egon Weinmuller from BASF was somewhere on this call. You should know that the Interceptor G2 product that is making such a big impact at the moment would not exist except for his personal commitment that he drove that forward in BASF and wouldn't let them walk away from it. So the thing that would most encourage those people to continue would be confidence that their work would result in products coming smoothly through the qualification process and clarity about what they have to do to bring through. They're happy to do the work to bring it through. They just want it to be clear and straightforward and reliable. I'll stop there.
I think we've come to the end of the class. Frederick, you're muted.
No, I say thank you.
Abdullah has been waiting for a while. I'm not sure if he said something or you're overlooking.
Abdullah, would you like to finish for us? Hello, Dr. Abdullah? Dr. Abdullah, entomologist. Entomologist Swiss. Dr. Abdullah, are you there? You're muted if you're speaking.
I think he can't hear you.
Yep, now.
Yes. And I was late because and question for you. The slides, inshallah. Thank you.
All right, thank you so much. I think for us is to say a big thank you to everybody for participating today. This has been an incredible conversation. Thanks to all our experts for joining today. We apologize for keeping you for 3 hours, but I think it's been very useful for our audience and for all the stakeholders who joined, the researchers, the students, the NMCP staff who joined, the financiers, the funding partners, everybody who gets to join these master classes. We are grateful for your participation and more so grateful for our experts. Thank you so much, Abdisalam Noor, also for preparing the initial material and providing that initial overview. Obviously, this would have been like 3 master classes in one. We always tend to over-prepare. We learn to prepare less so that we have more time discussing, but 3 hours in-depth conversation on a subject appears not to be enough, but we think it should be enough. Otherwise, really just being grateful for this. I would like to say a special thanks to Nana, my co-host Nana Abba Williams from MESA. Nana, thank you so much for a continuous partnership in this, and going forward, I hope that together we can make this even better. I'm also would like to say thank you to my colleagues at Ifakara Health Institute for supporting in the background, my colleagues from Ifakara and also from Dar es Salaam, Zawadi Mageni, Halfan, Rajat, Lena, Finda, everybody from Ifakara who is supporting the masterclass in different ways. Thank you all so much. And I think I should end it there and ask Nana to close.
Okay, thank you very much to everybody. I think Pedros has said it all, but I think the take-home message really is that to solve the malaria problem, it requires innovation, some of which we've talked about today. We need new strategies and we need to think differently about how we solve the problem. And then there are bits we wanted to discuss, but there wasn't space for that today. And like Noor said, is another space for discussion in a different masterclass on issues regarding innovation in counting surveillance, and also operational research and implementation science. These are very important topics as well as we talk about scaling up those new innovations that we've talked about today. So thank you very much to everybody, and the attendance is very much appreciated.
Thank you, Pedro and Nana. We really enjoyed participating.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you. Thank you. Thanks, everybody.
Thank you.
Thank you.
Thank you. Thank you.